On behalf of the Sri Lanka Medical Association and the Galle Medical Association, it gives me immense pleasure to welcome you to the foundation sessions of the Sri Lanka Medical Association hosted this year in collaboration with the Galle Medical Association here in the beautiful city of Galle. This event marks a significant milestone in fostering academic excellence and strengthening the bonds between our associations. To commence today's proceedings, I now call upon Dr. Ananda Vijayawikrama, President of the Sri Lanka Medical Association, to deliver the welcome address.
Good morning. On behalf of the Sri Lanka Medical Association and the Galle Medical Association, I welcome all you to the second day of our foundation session. We have a full day program with very relevant and important topics which are relevant to date, and also we have very eminent speakers lined up today. In addition, we have an oration too, and I think it will be a very fruitful day for all of you. And I would like to take this opportunity to thank the Galle Medical Association for helping us in having this collaboration here, and also the faculty, staff, and the dean for providing this nice auditorium for this. And I wish you a fruitful day for all of you. Thank you.
Thank you, Dr. Vijayawikrama, for your words and a warm welcome. Next, I'll call forward to the podium Dr. Vimalasiri Uluwathage, President of the Galle Medical Association, to address the gathering.
Good morning. Good morning, ladies and gentlemen. On behalf of the Galle Medical Association, I would like to warmly welcome all of you as we commence on the academic program of this historic foundation sessions, a collaboration between Sri Lanka Medical Association and the Galle Medical Association. First and foremost, I extend my heartfelt gratitude to the President, Dr. Ananda Vijayawikrama, and his Executive Council of Sri Lanka Medical Association for partnering with the Galle Medical Association to bring this significant event to Galle. This collaboration is a testament to the unity and shared vision between SLMA and GMA. I profoundly thank in advance Emeritus Professor W. Indral De Silva for his keynote speech, and also thank the orator Dr. Nilanka Wickramasinghe for delivering Sir Marcus Fernando oration. My sincere thanks also go to all the resource persons who have generously contributed their time and expertise to make this academic program a success. The organizing committee representing members from both SLM and GMA deserves a special thank for meticulous planning and organizing an event of this magnitude. This collaboration serves as an excellent model of how professional organizations can work together to address regional health challenges while sharing expertise for the greater good. By holding this program in Galle, we have not only brought national attention to the regional health issues, but also created an invaluable platform for exchanging ideas and building strong professional ties. Let this academic program serve as a symbol for our commitment to learning, collaboration, and service. Thank you, and wish you all an enlightening and productive day ahead. Thank you.
Thank you, Dr. Uluwathage, for your welcoming words. Ladies and gentlemen, Moving on to the keynote speech, we are honored to have with us Emeritus Professor W. Indralal de Silva, a distinguished academic who has made remarkable contributions in the fields of demography and strategic studies. To introduce and read the citation for Professor de Silva, I call forward Dr. Anantha Wijevikrama, President of the Sri Lanka Medical Association, to the podium.
I am honored and privileged to introduce the Emeritus Professor Indralal de Silva to this audience. Professor Indralal de Silva obtained his Bachelor of Development Studies in Statistics with a second-class upper division from University of Colombo in 1977. And then he went on to obtain a diploma in Population Studies with a first class from International Institute of Population Science, Bombay, and then a Master's of Arts in Demography from National Centre of Development Studies, Australian National University, Canberra, and then a Doctor of Philosophy in Demography from Department of Demography, Australian University, National University of Canberra. During this period and after that, he obtained many other professional appointments, held many other professional appointments and obtained qualifications by working as a tutor in statistics in the Australian National University of Canberra in 1987 to 88, then working as a postdoc fellow in the same university, doing research on husband-wife communication on reproduction, reproductive intentions and subsequent behavior, etc., teaching for MA in a demography program. And then furthermore, he proceeded to Boston, USA, obtaining a senior Fulbright fellow in research on maternal health, which he continued from 1996 to 1998. And then in 2004, he worked as a research fellow on research on marriage trends and family transition, etc., in the Asia Research Institute of National University of Singapore. Professor Indralal de Silva had been working as a former research fellow in National Centre for Advanced Studies in Humanities and Social Sciences in UGC Colombo. He was the former Executive Director, Regional Centre for Strategic Studies, Colombo, and he was the former Senior Professor and Chair of the Demography and the Dean of Faculty of Arts in University of Colombo. So we are privileged to have this very senior professional with a lot of experience in demography, especially related to health sector. And I am very thankful to Professor Indralal de Silva for accepting our invitation to deliver the keynote address in the foundation sessions. Over to you, sir.
Good morning to all of you. Thank you very much, Dr. Anantha Wijevikrama, for a kind introduction. Well, I'm going to make a brief presentation by taking about 30 minutes. And my presentation is on emerging demographic dynamics and sexual and reproductive health issues in Sri Lanka. Well, I'll be covering basically the demographic behavior we are observing, the drop of births, that means fertility decline, and drop of marriages and rise of deaths in Sri Lanka in an unexpected manner. And also along with that, the population of Sri Lanka is declining right now, and also our labor force is itself declining, and our age structure is changing. We are going to have very small number of children in future and diminishing the number of youth, and also rising very rapidly the number of elderly people, and also implications. If you look at this particular graph, you can observe that very easily life expectancy of Sri Lanka and South Korea. Because I have selected South Korea because people know that South Korea was not a well-developed country about 30-40 years back. If you look at 1962, Sri Lankan life expectancy at birth was 63 years. But South Korea, it was 55. But 2022, Sri Lanka rise to 77, but South Korea 83. That means 1962 we had a 8 years advantage compared to the South Korea. But now South Korea is having 6 years advantage. If you look at the fertility, the production of live births, Sri Lankan fertility was much lower in 1960s. We had only 5.3 children on average per woman, but South Korea it was 6.2. They had higher fertility. But 2022, South Korea is the world lowest fertility in the world now. They are producing per woman, the replacement level fertility is 2.1, but their fertility is 0.7, which is very, very low, the lowest. Sri Lanka, we don't have data for the latest period, but it should be around 1.5, the total fertility rate. Therefore, you can observe that what kind of changes has happened in South Korea. And if you look at this particular graph, you can notice the more or less same thing. Until up to 1971, Korean fertility was higher than Sri Lanka. Since then, the reverse has occurred. But you can see the right-hand side. Sri Lanka, we don't have data, but after 2016, but right now it may be around 1.4 to 1.6. And what are the demographic changes we are observing right now? And you can observe this particular graph, very simple graph, anyone can understand. I am reading the bottom part of it. The births dropped from 336,000 in 2015 to 319,000. Therefore, the drop is only 4.7. 2015 to 2019, the drop of fertility was less than 5%. But if you consider the period 2019 to 2023, that 5-year period, we can observe that fertility has declined by 22%. 22%. Therefore, massive decline we are observing the recent past compared with the 5-year period starting from 2015 to 2019. If you look at the changes in marriage, because marriage is the one key component influencing fertility in Sri Lanka. Therefore, you can notice we had large volume of marriages, something like 177,000 2015, but we are now observing 151,000 marriages in 2023. And 2024 and onwards, these numbers will come down further. Now you may have a question on your head that why the Sri Lankan reproduction or the fertility is dropping very significantly. The number one, of course, contraception, emergency contraception, and abortion, medical abortion, and I have done a lot of work about the medical abortion, how rapidly Sri Lankan population is now familiar with the medical abortion, RU486 and other available pharmaceuticals, and drop in marriages, and also rise in divorces. Probably you may be not knowing that I am extracting this data from the Minister of Justice. They are claiming that every day the lawyers in Sri Lanka, they are submitting 300 divorce cases for the courts per day. Therefore, you can imagine per year how many divorce cases are filed by the lawyers to the courts. and also separation and social divorce also very high. That also contributing for the decline of fertility. And also interestingly, second bullet, sizable proportion of youth do not wish to get married due to various reasons. And also COVID-19 and economic recession, there are multiple effects. One simple effect is that the decline of real wages, the inflation and the price of the goods. The value of children has declined significantly. Children are too costly. Therefore, people, they get married, they postpone their reproduction. And people who have only one child, they postpone the second birth. Therefore, there are many reasons why marriages are dropping and those who get married and why they are not producing children. And another interesting component is migration, which I am not going to discuss, but we know that large number of Sri Lankan youth, say 15 to 29, they are planning to go abroad for various reasons. And also large numbers are leaving. They are largely male. And then there are sizable number of females are here, but they don't have suitable male partner to get married. And also there are some males, particularly I know that from our research, they are intending to migrate. Therefore, they don't want to get married right now, but they are in the marriageable ages. And also subfertility. I don't think I should explain anything about the subfertility in Sri Lanka. We know that only the rich people can go for the particular private hospital and get the subfertility treatment, which cost about 3 million to 4 million. But success rate, I know I checked with some of the experts in this field, like Professor Harsha Senuratne, 30% is the success rate. Therefore, poor people, basically they do not wish to go for waste that much of money. And the public sector, FHP or any other organization, do not provide significant service on subfertility. Therefore, probably subfertility also increasing, and in the same time the treatments are there, but success rates also low. And also very important last item, the climate change, the global warming, multiple effects are there. And drop of births, now this is very important for the health planners, health professionals, and also many other professionals, even the education field. Drop of births, what could be the implications? Number one, the number and proportion of children will decline. Therefore, naturally, we know that large number of schools need to be closed down. And some of the children far away, they will get admission to the top level schools because there are no children around that school. And also definitely the demand for OBGY will decline because pregnancies are dropping, and then confinements are dropping, childbirths are dropping. Therefore, naturally OBGY services are going to be somewhat lowered in the system. Pediatric service, definitely, again, because suppose there are a number of children dropping, pediatrics will come down. We expect in the same agenda decline in MMR and IMR. Maternal mortality and infant mortality, we expect a decline because number of births are declining, but unfortunately during last 2-3 years we are observing increase of IMR and increase of maternal mortality rate also slightly. But our expectation was that once the confinements, pregnancies are dropping, it should further come down. Closing of schools and also impact on the economy is a very significant factor, because I don't think I should explain, you can understand that one. Suppose you have a very small number of children, once they complete their education, they will enter into the labor force. But once the numbers are smaller and large numbers are retiring, once the number retiring, number entry is quite low and there is a small number in the labor force. Therefore, they have to pay the taxes for the social security, social protection for large number of people, particularly for large number of elderly in the country. Therefore, rapid aging, a very enormous number of elderly people we are going to have. Sri Lanka, therefore, I tend to argue in most of my publications, high life expectancy but with high morbidity conditions. Therefore, Sri Lankans live long but having so much of health complications. And also rise in rapid aging, and very importantly, you are going to observe this one, couples as well as elderly couples with no children. This is going to be the emerging scenario in coming era, because some of the couples don't have children, and large number of couples, they do have children, but they are all gone. Therefore, we are going to observe solo living or only the couples alone living. Therefore, social protection, social security is going to be a serious challenge for them. At the same time, number of deaths also rising very rapidly. You can observe, I am reading the very bottom, the bold line, the increase of death from 2015 to 2019 was only 5%. 2015 to 19 5-year period, just before the COVID, the rise of deaths only 5%. To some extent that can be attributed for population aging and also some other reasons. However, 2019 to 2023, the rise of deaths was to over 25%. Therefore, Dr. Ananda Vijayvikrama was here, that he knows exactly the COVID impact, and probably we are experiencing vaccination problems, probably viruses. People didn't die, but they may be having all kind of complications. But what I'm saying is that premature deaths are happening very significantly. But we don't know anything about life expectancy of Sri Lanka right now. But very importantly, before COVID, the rise of deaths only 5%, now it is over 25%. Now life expectancy, if you look at Sri Lanka in the 1920s or 1960s, if you take 1960s, females started having little longer life. Men 63.3 years, females are 63.7. Females enjoy half a year long life, but by 2011-13, females are enjoying almost 78 years of longer life, but male are 72 years from birth. Therefore, males are enjoying about 5 years of longer life compared to the male. And also look at the bottom one, after celebrating 60th birthday, females can live about 21 years. That means they can withdraw their pension benefits for 21 years. But males are only about 17 years. But these are somewhat old. We don't know anything after 2012. But I tend to believe to some extent that I have mentioned that one in the middle. During the recent period, IMR has increased. Thus our life expectancy may remain more or less same, or it may be slightly decline even. But we don't know exactly. Now, a significant drop in births, net negative international migration and rising deaths will suppress the growth of the Sri Lankan population, and structure is changing. Now if you look at this particular graph, summarizing what I said, the blue bars represents the size of the Sri Lankan population. By 2022, we had our population was 22.2 million, 22.18, 2022. Since 2022, our population is declining. Probably most of you may be not knowing that one. 2023, it was around 22 million, but now it is lower. And also, even I have suspect that our mid-year populations are somewhat exaggerated. Why I am saying is like that, if you take the election information, nearly 5.5 million people, registered voters, they did not vote. Do you think all they are in Sri Lanka? They are in abroad, sizable numbers. But the household maintain large number of people as resident population of Sri Lanka. But actually they are not in the country. That's why over 5 million voters, they did not came to the polling stations. Therefore, 2024 census is very vital but we don't know how successful is that going to be, because we are not going to ask them, okay, tell me how many people are inside your household, show me them, count them. But we don't do that one. We ask from the head of the household, how many people you have in your household, that's all. Therefore, the numbers say we have more people, but actually numbers are dropping now. The drop may be even more than this. That's what I am saying. Now, I have made large number of publications on population projections of Sri Lanka. UNFPA, the latest projection done by me, and I have 3 projections made for the health policy analysis people and also IPS, and I tend to believe that my projection which I made on 2007, which I captured that population is declining, that was more true than the latest publication made for the UNFPA. Now I am moving to another important area, why it is important to study SRH issues among the youth. Well, youth are the future of any country. Youth bulge we observed in Sri Lanka, India, Bangladesh, etc. Youth development and then youth-led development is very important. Youth development and youth-led development of a country. However, youth are very vulnerable on SRH situations that would jeopardize their well-being and development of the country, that we are observing this kind of scenario also. Therefore, identification of the SRH knowledge, attitudes and vulnerable practices are very, very important, and developing appropriate policies and programs. I am going to present you something different agenda now. SRH issues among unmarried youth in Sri Lanka. Their love affairs or intimate relationships, sexual behavior and sex partners, capturing their vulnerability. If you look at here, the blue bars, from some of our historical information we have currently having love affairs among the youth in Sri Lanka, unmarried. 1998, among the males of 15 to 24, only 39% has a love affair. But year 2000, our survey, my team, we had done a survey, and 83% of the youth have love affairs. Among the females, 1990 it was somewhat lower, 29%. They are not very happy to declare their love affairs in 1998, but look at year 2020. Over 86%. The females are having more love affairs than males. Probably running into the males are having multiple love affairs, maybe one in online, maybe one in physical, or somehow it is true. Most of the faculties I tend to teach, the medical faculty also, I know more than 60% is females. Arts faculties, law faculties, education, more than 90% is female. Therefore, more and more females enter into the higher education, but the problem is that they don't have suitable marriage partners. And why these love affairs are very high? Well, school education, higher education, tuition classes. You can see that in higher education class, they are not that happy. But in tuition class, they are very happy. Right? But mobile use, very high. Sri Lanka, we have more mobile phones than the people. And also, people tend to observe films, songs, and social networking and all kind of YouTube platforms. I don't think I should explain. All of you know. Now, if I ask from you, compared to the past, now you may ask that today love affairs are significantly higher even among the 10 to 14 age group. Even age 10, the young children have love affairs. Sometimes they don't know exactly what is meant by love affair. Well, is this an issue or problem? In what sense? Well, it's a biological need and a hormonal reaction. But there is violence, hate, frustration, suicide, even killing, and separation and divorce. I don't want to go tell you many things, but if you look at multiple love affairs, and after one dropping and another one is starting, keep on continuing. And then after marriage, we are observing that significant domestic violence, and we tend to suspect that some of their past behaviors are linked with this current domestic violence. Separation and divorce, I already mentioned that divorces are the maximum point that come to the courts, but between that, marriage and divorce, there are so much of social divorces and separations are there. Probably some link is there. These love affairs are contributing for that. Because what I am saying is that starting love affair at very young age, definitely you are exposed to have number of love affairs. That's what I am saying. That leads to some sort of risk factor. Love affairs has been there since one cannot say that love affairs is something wrong. It is a natural thing. Love affairs have been there since the origin of mankind. If you take the aesthetic field, love is the most pronounced phenomenon presented through the songs, films, teledrama, paintings, novels, etc. I want to show you 2 photographs just to check your, which kind of interest you have. This is Monument of Love, Taj Mahal. My first education from India, Bombay. Therefore, even though after that I was in Australia for a long period. Therefore, you can see this particular diagram or the photograph. How many of you like this photograph? How many of you like this photograph? This photograph taken in the just before the night. This one, very daylight. Which one you like? I don't want to ask from you, but it captured here. It is something, if you take this particular, vulnerability, what I explained here, it is to some extent related to our music or our film industry and so on. Therefore, if you look at the films produced some time back, 1960s or 1970s or even early 2020s. Therefore, if you look at Sinhala song or the Hindi songs or Tamil songs or whatever the songs, that present the spiritual love, not the lust love, the spiritual love. Therefore, if you look at this particular song which was produced in 1960s, what it says, fulfill the promise that was made. Even after the death, that is not possible. But it says the meaning of that particular song. But I don't think you will understand what is this song if I put the rhythmic structure onto it. Everybody in this class, probably except our very young crowd, all others will understand. Let me put you to the rhythmic structure on it. जो वादा किया वो निभाना पड़ेगा, रोके समाना चाहे, रोके बुदाए तुमको आना पड़ेगा, जो वादा किया वो निभाना पड़ेगा, निभाना पड़ेगा. Therefore, except from my basic education on human fertility, mortality, migration, I have some knowledge on some particular areas also. But if you look at the Sinhala song, which was sang originally by Victor Ratnayaka, promotion of spiritual love. Saint Suran Ralle, the basic meaning is that smell of love in the breeze. I believe all of you know this particular song. But if you compare the song below, the right hand side, song is very good. Music, vocal colors, presentations are very good. but what is the lyrics indicates. Develop the love affairs as soon as possible and enter into the sexual behavior. You can, I'm not saying exactly that's the meaning, but if you read the second verse, Anam Surangana Kveniya, Bonna Venne Dhammika Peniya, Innata Babam Make Kella, that's what it says. Therefore, it has no idea of spiritual love, but on a dancing floor, they are basically asking people to develop some sort of love affair and go for the somewhat advanced level. But if you look at the first one, smell of love in the breeze, it's a very different story. We are producing more songs belongs to this right hand bottom. But if you look at the first one, rhythmic structure, Sihil Sulang Ralle Obe Suvende Musuve Adare Mad Sinidu Pahas Lab Hadvete Dalu Selave Sihil Sulang Ralle Obe Suvende Musuve. Therefore, even same thing happening in the most of the world. Even you go to India, presentations are not spiritual love. Most of you might have heard Sari ke folasa kabhi mech ke aare. Very much promotion of lust love. Most of the countries, even Sri Lankans are hearing Korean music. But I don't know, I have a number of friends from Korea, but I never know the Korean language. But I don't know why our youth are preferring music industry is concerned Korean and rather than Sri Lankan or English or Hindi or Tamil or whatever which are close to us. Okay. Finally presenting some interesting era. Sexual intercourse, now love affairs, and other parties you can notice that 15 to 19 group is concerned. Look at the males 15 to 19. Unmarried males 15 to 19. 22% of the unmarried males have sexual intercourse experience by that time, within that age group. Once we look at the 20 to 24 age group unmarried, 29% of them already have sexual intercourse experience. Therefore, if you look at the females, at the young age, it was only 9%. But 2024, 12.7, quite high. It is, one may say that, so what? Well, on the health or medical terms, you can argue on this field. Majority of the lovers, they have sexual experience, sexual intercourse experience with the lover. But look at the commercial sex worker. Almost 15% of the males in the 20 to 24, they had sexual intercourse experience with the commercial sex worker. And therefore, I am noticing that HIV is increasing and also so many other issues are there, but even look at the younger age, 6.3 of the unmarried youth, already they had experience with the sex workers, female sex workers. And also interestingly, unknown person. Therefore, that Anam Surangana Kveniya, Bonna Venne Dhammika Peniya place, definitely unknown person they are meeting, right? Therefore, unknown person almost 10% of the very young people, right? And bulk of the things I have presented to you based on some of my recent publications with my staff and my team. You can see that whatever I presented on, published by the National Science Foundation, changes in demographic components during 2019 pandemic, and that was published by Dr. Malik, who is doing MD in New Zealand in my research team, and BMC journal. In our study, unmarried Sri Lankan youth and sexual behavior and conceptive use. All are basically published material. And also 2020, we had a major publication with the Child Fund covering large unmarried Sri Lankan population, and I had another publication in 2008 with the Plan International, and these are the publications. And then last 15 minutes, my questions. Why are births dropping at alarming rate? It is not only for me, even medical profession is worried about that. Of course, consultants may be worried also, no doubt about it. Why are deaths rising at an alarming rate? You know, why it is rising at alarming rate in Sri Lanka? Due to what particular reason? Is it diabetic, hypertension, or heart diseases, or whatever? And stress levels. Because most of the time, whatever the audience I speak, I make sure that audience is relaxed and they enjoy my presentation. But I know that our students are very stressful. They are not in a very happy mood. Their intention is to go out somehow, one way or another. Therefore, why this sizable proportion of youth are vulnerable? As adults, we have a responsibility to look at that one. And also it is very, very important, the last bullet. Why it is difficult to implement comprehensive sexual and reproductive health education to the school children and young out of school children. Therefore, these are the questions we discussed recently. Also, one of the international conference we had, we organized a large number of participants were there, education ministry and so many people, but we know that this is going to be a difficult task, very difficult task. Therefore, having all these things, thank you very much and inviting me, and I believe you enjoy my presentation. Thank you.
Thank you, Professor De Silva, for that insightful address. Now, I'd like to invite Dr. Ananda Wijevikrama, President of Sri Lanka Medical Association, to present the Certificate of Appreciation to the keynote speaker. Thank you, sir. The dignitaries of Sri Lanka Medical Association and Gaul Medical Association will now leave the auditorium to join the ceremonial procession. Others, please remain in the auditorium until the arrival of the procession. please rise as the joint ceremonial procession of the Sri Lanka Medical Association and the Gaul Medical Association enters the venue. Once again, I'd like to invite the following dignitaries to the head table. The President of the Sri Lanka Medical Association, Dr. Ananda Wijevikrama, the President of the Gaul Medical Association, Dr. Vimalasiri Uluwathage, and the orator for the prestigious Sir Marcus Fernando oration, Dr. Lanka Wickramasinghe. The oration is an event where we honor the tradition of scholarly excellence. Ladies and gentlemen, we now come to the highlight of today's academic event, the prestigious Sir Marcus Fernando oration. To introduce the orator, Dr. Lanka Wickramasinghe, and the award the orator's medal, I call upon Dr. Ananda Wijevikrama, President of the Sri Lanka Medical Association, to the podium.
Good morning once again. It's a great pleasure to introduce this beautiful, multi-talented lady, today's orator, Dr. Nilanka Anjali Wickramasinghe. She graduated from Faculty of Medicine, University of Colombo with the second class upper division in 2014. Following that, she obtained a master's in human nutrition from Postgraduate Institute, University Colombo, topping the batch and obtaining the gold medal from the PGIM in 2019. And also she got the gold medal for best performance at the MSc Nutrition examination in 2019, awarded by the Sri Lanka Medical Nutrition Association. After that, she joined the Department of Physiology, Faculty of Medicine, University of Colombo, as a lecturer in physiology in 2018. She recently completed her PhD on gastrointestinal physiology from the University of Kelaniya and is currently performing the clinical service of GI physiology investigations at the National Hospital of Sri Lanka. Lanka has more than 12 publications in Index Journal. Her and also obtained an international patent on a detachable sole for corn and callus affected feet, which was obtained in 2024. She was also awarded the President's Award for Scientific Publication for 2014 and 2015 from National Research Council, as well as the Merit Award for Scientific Publication for the year 2016 from NRC. She has also presented many scientific communication winning awards during Sri Lanka Academy of Young Scientists 3-minute thesis competition, Physiology Society of Sri Lanka annual scientific sessions, Ceylon College of Physicians scientific sessions, and 9th Asian postgraduate course on neurogastroenterology and motility. During the year 2024, she was awarded the United European Gastroenterology International Scholarship Award in Austria, the Asia Pacific Advanced Network Fellowship in Pakistan, and the Professor K.N. Senaviratne Memorial Research Award from the Physiology Society of Sri Lanka. Nilanga obtained her postgraduate certificate in medical education, University of Colombo, and SEDA accreditation from UK, and has won multiple Teach Excellence Awards from the University of Colombo. She has also authored several books, which include books targeted at medical students, Simplified Physiology of ECG, as well as a series of 16 books targeting small primary grade children on body and health issues and safety from molestation. She also co-created and acted in a TV series on health targeted at the general population on educating them on various important aspects, together with the Sri Lanka National Television Rupawahini, coordinated by the Colombo Medical Faculty. In addition to her academic qualifications related to medical field, she is a trained singer and a pianist with a LTCL diploma in vocals and ATCL diploma in piano from Trinity College, London. Her husband is Professor Dakshita Wickramasinghe, a surgeon, and they have 2 children. It's a great pleasure to invite Dr. Nilanka Wickramasinghe to deliver this oration, and I kindly invite her to come forward and accept the Orator's Medal.
Good morning, ladies and gentlemen, and thank you, Dr. Ananda Vijay Wickrama, President, Sri Lanka Medical Association, for your kind introduction. I'm deeply honored and thankful to be chosen by the SLMA to deliver the Sir Marcus Fernando Memorial Oration, and I also thank the Gaul Medical Association for hosting this event. And I will now start my oration by honoring Sir Marcus Fernando. Hilarion Marcus Fernando was born in 1864 in Colombo, Ceylon, to a prestigious family. He was first educated at St. Benedict's College and then the Colombo Academy, now known as the Royal College, Colombo. He received a government scholarship enabling him to study medicine at University College London, where he graduated with a BSc, obtaining 4 gold medals, and later with a MB and MD. He was also selected as a Fellow of the University College London. He married Lady Frances, a daughter of the famous Charles Henry Deseza, and lived with his family in his home near Greenpath, where his grandson lives even now, in the Sir Marcus Fernando Road. During his tenure, he served in the roles of the Registrar of the Ceylon Medical College, the Superintendent of the Deseza Maternity Home. He was the first consultant physician to be appointed to the General Hospital Colombo, and he was the founding director of the Bacteriological Institute in Colombo, and he was the president of the Ceylon branch of the British Medical Association. At the age of 43, he resigned from the medical service to take up a career in business and politics. He supported enabling general elections for Sri Lankans with activists during his time. Sir Marcus Fernando was a co-founder of the Bank of Ceylon and a co-founder of the University of Ceylon, to name a few. He was made a knight in recognition of his many achievements, and he is a testament of the fact that doctors need not be only healers but also leaders in society. Now, let me start on the topic of my oration, gastroesophageal reflux disease, or GERD, in Sri Lanka, an overview. This oration is a culmination of the hard work conducted over the past 4 years for my PhD. This is the outline of my talk. Most of the images I will show in my slides are original images extracted from my thesis and from the 2 review articles on GERD I have written and which are in press for the World Journal of Gastroenterology and the World Journal of Gastrointestinal Pharmacology and Therapeutics. I will start with discussing what is GERD. GERD is a condition where the contents of the stomach reflux back into the esophagus, causing symptoms such as heartburn and regurgitation. The pathophysiology can be categorized as supraesophageal factors such as impaired reflux-induced swallowing, esophageal body-related factors such as ineffective esophageal motility, esophageal junction-related factors such as hiatal hernia, and gastric-related factors such as delayed gastric emptying. Other than the typical symptoms of heartburn and regurgitation, many symptoms and conditions are associated with GERD, such as chest pain, bloating, and even asthma. What about the prevalence of GERD symptoms? A systematic review by Nirvan et al. Done in 2020 reports that the global prevalence of GERD symptoms, defined as heartburn and or regurgitation at least once a week, is nearly 14%, with Western countries reporting a higher prevalence. But you will notice that Sri Lanka is not included in this systematic review, and we do not have any prevalence studies done in Sri Lanka in the community to include in this. My research on Sri Lankan GERD prevalence, published in the PLOS Global Public Health Journal, aims to fill that gap. I conducted a cross-sectional study on 1,200 adult Sri Lankans recruited from all 25 districts of the country using stratified random sampling. The island-wide GERD prevalence of symptoms defined as heartburn and or regurgitation at least once a week was reported as 25.3%. The highest prevalence was noted to be in the districts of Monaragala and Mullaitivu at 40%, while the lowest was in Trincomalee at 10%. There was no effect on urban and rural settings related to GERD symptoms. Alarmingly, of the population, nearly 40% were on GERD medication and 1/5 of the population were on proton pump inhibitors at the time of questioning. Thus, the prevalence calculated for Sri Lanka is much higher compared to the estimated global prevalence. This is indeed an alarming finding. Now let's discuss factors related to associated, related to the associated factors of GERD and GERD-related symptoms. When reviewing worldwide literature, factors associated with GERD symptoms are many and be categorized as diet-related habits, obesity, mental stress, and many others, including sleep habits, disease conditions like asthma, and hiatal hernia. Related to the Sri Lankan setting, using validated tools and questionnaires, as mentioned in the previously mentioned all-island study, we noted that increased mental stress, inadequate sleep, sleeping within 2 hours of a meal, skipping breakfast, and snacking at midnight were significant factors associated with GERD symptoms in Sri Lanka. Of them, mental health or mental stress played a significant role, and we published our further findings related to GERD and stress in the PLOS One journal. What about food? Nearly 1/3 of the adult Sri Lankans complained of heartburn on consuming food such as spicy food, oily food, bread, and to a lesser degree wheat, sour food, tea, etc. Of this, bread is an interesting finding, as it is not listed as an associated dietary factor in the Worldwide Literature Review. In this crowded table, many diseases such as functional heartburn, gastritis, etc. mimic the symptoms of GERD, causing some confusion with this disease. Therefore, in my research, I conducted a case controls analysis to identify the associated factors related to diagnosed GERD. This was presented as an abstract at the International Union of Physiological Sciences. The cases were patients diagnosed as having definite GERD from the National Hospital of Sri Lanka, and the age and sex match controls were those with no GERD symptoms at all, recruited during the island-wide study I mentioned before. Factors significantly associated with GERD were lower family income, asthma, consuming a midnight snack, inadequate sleep, inadequate physical activity, and mental stress. GERD patients were thinner than controls, and a lower daily caloric intake was observed, possibly due to the multiple dietary related restrictions because of spice, oil, and bread, etc. Let's talk about the diagnosis of GERD. There are multiple methods, starting with clinical history taking, which is notoriously unreliable. Endoscopy can diagnose GERD patients who have developed the complication of erosive reflux disease due to acid reflux. But this was seen in only 30% of patients in the Sri Lankan setting during our research. What about the rest of the GERD patients with no erosive findings? Thus, the recommended gold standard diagnosis in international guidelines to diagnose GERD is to do a combined 24-hour pH impedance testing. Here, there are two elements being tested in the esophagus using a specialized nasogastric catheter with sensors. One is pH, the other is impedance. Impedance is similar to electrical resistance, and I will explain it further later on. The pH impedance data is fed to a device worn outside the body, to which the patient also has to input symptoms, meal times, etc. If the esophageal pH falls less than 4 for more than 4% duration of a 24-hour period of testing, that patient can be considered as GERD. Meanwhile, impedance, similar to electrical resistance, will reduce when liquid is moving through the impedance sensor. Whereas movement of gas, say like a burp, will increase the impedance value. As there are multiple impedance sensors along the length of the esophagus, different types of movements can be identified using the patterns. Of this, liquid reflux is important for the diagnosis of GERD. If the patient's symptoms occurs within a 2-minute window of liquid reflux, it is said to be a positive symptom association. Thus, using the pH impedance data, we diagnose patients as having symptomatic GERD if they have increased reflux and a positive symptom association, asymptomatic GERD if they have increased reflux but a negative symptom association. If there is a normal level of physiological reflux with a positive symptom association, they are diagnosed as reflux hypersensitivity. If there is no symptom association and no reflux and no alternate diagnosis can be given, they are then classified as having functional heartburn. In our hospital cohort of 209 patients with symptoms of GERD to National Hospital of Sri Lanka, 95% of patients had upper GI endoscopy performed on them, but only 23% of the cohort underwent pH impedance testing done by me. This lack of pH impedance testing meant that almost 57% of our patient cohort, shown in this green color, did not have a diagnosis made related to their symptoms of GERD. Only 28% of the 46 patients whom we did pH impedance testing were diagnosed as having GERD in this red color area, while around 18% were diagnosed with reflux hypersensitivity and around 13% were diagnosed with functional heartburn. The management of functional heartburn is different from GERD, and if not identified, these patients will have a poor response to proton pump inhibitors. We also identified that newer metrics such as post-reflux swallow-induced peristaltic wave index or PS with GERD. So was another metric, mean nocturnal baseline impedance, and it too was significantly higher in patients with GERD. In our list of methods to use to diagnose GERD, esophageal manometry plays an adjuvant role. Esophageal manometry studies the pressure changes related to the esophagus, which can trigger GERD, and 46% and 61% of our patients respectively had these disorders. Now let's move on to the management of GERD. Management of GERD is done in the categories of lifestyle modification, such as elevating the head end of the bed, left lateral position to sleep, avoiding oily food or trigger foods, avoiding meals before bed, etc. Medications are used, and these are most often proton pump inhibitors such as omeprazole, and there are other drugs as well. There are endoscopic procedures such as TIF and Stretta, and surgical procedures such as fundoplication. In this image, I have amalgamated the current worldwide management guideline practices from the American, British, European, and Asia Pacific guidelines. And it starts with confirming GERD first, then to treating GERD using lifestyle modifications and proton pump inhibitors. If the response is poor, the medical management is then escalated and can go on to involve surgical options or endoscopic options. Sri Lanka does not have its own management guidelines, nor do we have much research on current practices. So in my thesis, we recruited, as previously described, 209 patients with GERD symptoms attending the National Hospital of Sri Lanka, and followed them up at 6 months and 1 year's time. As seen in this graph, almost 90% of our patients were prescribed with proton pump inhibitors, with other drugs being prescribed or used in lesser amounts. However, at the end of the year, nearly half of our patients, as seen in this green bar, were not on any drugs. Around 1/3 of our patients, as seen in this yellow bar, were on proton pump inhibitors on their own recommendation, that is without a doctor's prescription and as and when required. We also noticed that patients were not adequately advised on lifestyle factors, and that only 11 out of 209 patients were offered surgical management. When questioning the satisfaction related to medication use at recruitment, 6 months and 12 months, a considerable number of patients, as seen in these red parts, were not satisfied with their medication, with many dropping out of using medication and not coming for hospital visits. Some reasons patients offered were that they are being prescribed the same drug over and over again without an escalation of management. We also did a knowledge, attitude, and practices study on 100 Sri Lankan doctors at the National Hospital of Sri Lanka and elsewhere, and this was presented at the United European Gastroenterology Conference in Vienna this year. We noted that many doctors did not know the importance of pH impedance testing in diagnosing GERD. Only half of them advised patients on follow-up visits, and about half of the doctors also advised patients to avoid bread, which is not found in international guidelines. So this fact of avoiding bread, and the point that many Sri Lankans comment that bread causes heartburn, and they assume that it is due to the yeast content, made me conduct another small study. The findings of this study was presented as an abstract in the International Union of Physiological Sciences Congress. I collected bread samples from 28 bakeries around Colombo and sampled the middle of it and cultured it for yeast or Saccharomyces cerevisiae. 11 of our 28 samples grew yeast, and the pH of this bread was significantly lower than the bread that did not grow yeast. Yeast is used in the making of bread, and it is supposed to be killed during the baking process. But certain unethical baking practices, such as using increased amounts of yeast to quicken waiting time and to decrease the cost related to staff matters, and also not adequately baking the bread so that the weight remains the same due to the water amount in the bread. And these factors can probably give rise to yeast surviving in the middle of the bread and causing GERD symptoms. However, this has to be researched further. Let me come to my conclusions and future perspectives. Prevalence of GERD symptoms is higher in Sri Lankans than the estimated global prevalence. Identifying true GERD via pH impedance testing is the cornerstone for effective management. For this, improving investigation facilities is a must, but in Sri Lanka, there are only about 4 to 5 centers active offering pH impedance testing both in the private and public sectors. Evaluating and managing associated lifestyle factors and especially mental stress should be a part of patient management. And these identified GERD patients need a definitive plan which includes proper medication, surgery, and review. A huge confusion of the patients, for the patients during my communication with them was the fact that GERD did not have a Sri Lankan name. Most of the time we had to communicate about these symptoms calling it gastritis, gastric, etc. So during my PhD, using the help of language experts, we coined the word Amasha Galanalika Pratibaha Rogya, and it directly translates to gastroesophageal reflux disease on Google Translate. I believe that naming a disease is an important step in identifying its problems. Now, to end my presentation, I need to show my gratitude, my appreciation, and give my heartfelt thanks to all those who helped me in my journey. My sincere thanks go to my 3 supervisors, Professor Niranga Devanarayana, Professor Nandadeva Samarasekar, and Dr. Itsuro Yasaki, whose invaluable guidance, unwavering support, and insightful expertise were instrumental in shaping and completing this work. This photo depicts Professor Niranga Devanarayana and me at my thesis defense. She has come all the way from Colombo to listen to my first oration today. She has gone beyond the role of a supervisor to that of a mother. She trained me in GI physiology investigations, and I have spent countless Sundays at her house, completed with meals of course, where she went through each word of my proposal, articles and theses. Words fail to describe my appreciation to you, madam. A further note of gratitude to Dr. Itsuro Yasaki, who took me under his wing at the Royal London Hospital in UK and trained me in GI physiology. Collecting the sheer amount of data in my all-island study with 25 districts during a time of COVID scares would not be a possibility without the help of my pre-interns at the time, Dr. Adhavan and Dr. Achini. We went in my little car, as seen here, due to funding issues all over the country, and it was indeed a joyful journey. I was also constantly supported by my workplace, or I would say my second home, the Department of Physiology, Colombo Medical Faculty. I'm blessed with supportive seniors and mentors there. I'm who I am today due to my wonderful parents. My regret is that due to ill health issues, they cannot come and listen to me today. My husband Dakshita is my rock and has always been supportive of me to achieve my professional goals in life, and holding fort with our 2 little ones, Nidan and Anjali. Dakshita is currently representing Sri Lanka at a conference in Indonesia. My sincere love goes to my mother-in-law and father-in-law who are here with me today, looking after my home and my kids while I was away for research and training for months, and giving me the constant motivation. My final thanks go out to the people of Sri Lanka who funded my medical education, and even through my PhD, through UGC and University of Colombo grants I got. I never realized the extent of how generous and welcoming our people are until my study. The community as well as patients were extremely helpful in giving their data for research. And in almost each house we went to, in all parts of the country, we were offered something to eat or drink. My country is truly a beautiful heaven on earth, and I'm proud to be a Sri Lankan, as witnessed here with my first sunrise experience in the east coast of Sri Lanka during my research journey. And I hope our country will rise like the sun rises. Thank you for your patient listening.
Thank you, Dr. Vikramasinghe, for sharing your invaluable research experience with us. Ladies and gentlemen, please rise for the ceremonial procession to leave the auditorium, following which we will commence the first symposium for the day. Please be seated, and we kindly request you to remain for a while until the symposia commence.
Good morning to all of you. I'm Dr. Padma Gunratna, past president of the Sri Lanka Medical Association. My co-chair is Dr. Upul De Silva from the Gold Medical Association. So now we would be moving on to the first symposium of the foundation sessions. It's on nutrition across the life course. I'm thankful for organizers for organizing this important symposium that carries something for everyone in this audience. The first speaker is Professor Sumudu Senaviratne, MBBS, DCH, MD, PhD. She is the professor in pediatric endocrinology at the Department of Pediatrics and the director of the Clinical Research Center for Complex Hormonal Disorders, Faculty of Medicine, University of Colombo. She is an honorary consultant, pediatric endocrinologist, Lady Ridgeway Hospital for Children, Colombo, Sri Lanka. She actively got involved in undergraduate and postgraduate education and clinical training and clinical research and has authored more than 40 research articles, indexed and peer-reviewed journals, and 2 medical textbook chapters. And she has been an invited speaker for more than 25 scientific congresses. So with that brief introduction, let me invite Professor Sumudu Senaviratne to make her presentation. Over to you, Sumudu.
Thank you for those kind words of introduction, Madam. Very good morning to you, ladies and gentlemen. So I think we all know that childhood obesity is a common problem, and we tend to attribute it to mostly unhealthy lifestyle as well as inherited tendency. However, there is a third dimension that I would like to discuss with you today, which has a profound influence but is quite neglected, and that is the importance of early life nutrition on this phenomenon. So over the next 15 minutes, I would like to go through obesity and its health implications, including the current statistics and the projections for the next couple of decades, and mostly about how early life nutrition influences the risk of both childhood as well as adult obesity. Based on this, let's also look at strategies to reduce childhood obesity and our role as healthcare providers in this scenario. So, obesity refers to the accumulation of body fat to an extent that it is harmful to health. When we consider children, it has physical and metabolic manifestations as well as a profound psychosocial impact given that they are subject to bullying and some social stigmatization. And we are sadly seeing children as young as 10 to 12 years presenting with type 2 diabetes driven by obesity at present. This graph shows the strong association between childhood obesity and adult obesity. So if a child is normal weight, then the risk of being obese as an adult is as low as 6%. But if they are overweight, this rises to 30%. Obese children have a 50% chance of being obese as an adult. And severely obese children, about 80% of them remain obese as adults. So this is a very important aspect that we need to consider. This graph shows the rates of overweight and obesity in Sri Lanka at present, and we can see that around a third of our population, adult population, is overweight or obese, and 10 to 15% of children are overweight or obese at present. This itself is alarming, but what is more alarming is the projections for the next 40 years. This shows from the rates at 2020 up to predicted rates at 2060. And you can appreciate that by 2040, around half of our population will be overweight or obese. And by 2060, more than 2/3 of the adult population are predicted to be obese or overweight. And this translates to a huge health cost burden
given the huge health burden, cost burden, and you can see the exponential rise in obesity which is going to happen. So obesity is a relatively new disease. It was, I think, first came into being a major problem about 75 years back, but it is growing very rapidly. And so, ladies and gentlemen, I invite you to take a moment to think why obesity rates are continuing to rise dramatically despite efforts by multiple agencies, globally and nationally, to control it. Oh, sorry. Okay, so as healthcare providers or medical students, you may have already appreciated that it's difficult to change established lifestyles when we are dealing with children or adults who is obese. And really this reflects probably an effect of dysregulation of their energy balance, which could be contributed to by an inappropriate early life nutrition. So let's look at early life nutrition. When I refer to early life, I am not going back just to the time of birth, but really further back to the time of conception. So we talk about the first 1,000 days of life, and that is from the date of conception up to time of birth, and then till the completion of the second birthday. And this period is a period of sensitive growth where there is a profound influence on lifelong health. You may have heard the saying sometimes that you are what your mother ate. This is because as a fetus, as an unborn child, we are entirely dependent on energy from our mother. So really the mother is our only source of nutrition, and this plays a profound influence on our lifelong health. So what are the causes of obesity? We all know that genetics and lifestyle play an important part. But really it is fundamentally a problem of energy balance. If our energy intake exceeds that of our energy expenditure, then the excess energy is stored in the form of fat in the body. And so there is this third dimension of developmental programming where if a baby was subject to either undernutrition or overnutrition during their fetal life, this predisposes them to a dysregulation of their energy balance. From the time of birth, they are at a higher risk of obesity compared to a child with a normal birth weight. This is an important graph showing birth weight on the x-axis and the risk of being obese or overweight in adult life. And you can see there is trouble at both ends of the birth weight spectrum. So low birth weight. So what are the reasons for fetal undernutrition and overnutrition? When we consider a baby who is born small for gestational age, one of the contributing factors which is still present in Sri Lanka is maternal undernutrition, especially in the estate sector of our country, the deprived areas. We still have babies who are born small because of inadequate nutrition. The other cause is placental insufficiency. When we look at babies who are born large for gestational age, then women who enter pregnancy in an overweight or obese state, or who develop diabetes or hyperglycemia during pregnancy, or those who have excessive gestational weight gain. All these are factors that contribute to a baby being large for gestational age. And with this, let's look at a story of 3 generations to see how this applies in clinical practice. So let's look at the 3rd generation first. Miss Methuki is a 6-year-old girl from Colombo 8. She was identified to have overnutrition at the school medical inspection in grade 1 and referred for evaluation. So her birth weight was 3.8 kilograms, and her mother had gestational diabetes, which accounts for the large birth weight, and she was thus delivered by a cesarean section. On examination, her BMI is above +2 standard deviations, which is the definition of obesity, and she has acanthosis nigricans, indicating she is insulin resistant. Her mother, Mrs. Diluika, is a 31-year-old garment factory worker. So she was born in a rural area in Ratnapura with a birth weight of 2.4 kilograms. But she moved to Colombo at 17 to take up a job, and she became overweight in the obesogenic environment in Colombo. She developed gestational diabetes during her pregnancy at 25 years, and at 30 years of age, she was diagnosed to have type 2 diabetes. She is currently obese with a BMI of 32. But more interestingly, let's look at the grandmother. So Mrs. Siriyavati, he's 55 years of age. She's a rubber estate worker in Ratnapura. She herself was born with a low birth weight of 2.3 kilos, but she has not left this environment, which is socioeconomically deprived environment, and continued to be underweight throughout her life. However, she is active and she has no chronic illness and is unlikely to develop type 2 diabetes. So you can see, ladies and gentlemen, that genetics is not the problem, it's lifestyle as well as the effects of early life nutrition. And Sri Lanka and many other low middle income countries in the world today still face a double burden of malnutrition. On one hand, we have undernutrition in the rural areas and overnutrition in the urban areas. And if a child is born in an undernourished environment and remains there, then they don't develop diabetes. But if they move from that to an environment of excess or obesogenic urban environment, then they would not remain at a normal weight, are more likely to develop obesity and diabetes. And their children are then likely to be large at birth and then continue to have this obesity in their generations. So going back to our 3 generations, Mrs. Siriyavati was born with fetal undernutrition as a small baby. And these babies develop a thrifty phenotype. Thrifty means that you save up. And so because they predict that they are going to be in an environment which is less in nutrition, these babies are programmed to store fat in their central region. But if they move from such an environment to an environment which is obesogenic, there is a mismatch between their prediction and what actually happens. And this leads to adult onset central obesity. This was described by David Barker et al. In the 1960s. And so that is what has happened to Mrs. Dulika. As she moved to the urban area, she developed obesity, and as she became pregnant, she developed gestational diabetes. Now her baby was then subject to fetal overnutrition and developed obesity at a very young age of 6 years. So we have Miss Methuki here, who is showing us the effects of this transition. So this is a busy slide. I just want to emphasize to you a little bit of the pathogenesis. So maternal obesity, gestational diabetes, are conditions where there is insulin resistance and therefore the mother is hyperglycemic. Therefore, there is increased glucose delivery to the baby, who then has to produce more insulin. And in utero, insulin is a growth factor, so these babies are bigger and fatter. And this exposure to extra insulin and leptin causes dysregulation of the adipo-insular axis. That means there is alteration at the hypothalamic level, and they can't regulate the appetite, activity levels, or energy as well as a child who is not subject to this. There are changes, epidemic changes that can persist, as well as, for instance, a cesarean section in Methuki also leads to changes in a gut microbiota, which is also now implicated in the etiology. So this effectively sets in an intergenerational obesity cycle, where a mother who is obese or has diabetes during pregnancy predisposes a baby to fetal neonatal obesity, which persists as childhood obesity and adult obesity, and this will perpetuate in subsequent generations. So ladies and gentlemen, I hope you appreciate the enormous problem that we are going to face due to this. And in recognition of this, the World Health Organization has advocated a life course approach to solve this problem. So we really need to start preventing obesity from a young age, starting not only on the girl child, on the boy child as well, but with special emphasis on the girl child. And it's important that young females achieve a healthy weight before they start planning their pregnancy. During pregnancy, if a lady is overweight or obese, then it's important to educate her that she does not have to eat excessively. We still tend to think that you need to eat for 2 when you're pregnant, but that is no longer true. And really, our population still think bigger is better when it comes to babies, but you can appreciate that is not really the case. Promoting breastfeeding is another good way of combating this, and we are fortunate in Sri Lanka to have very high rates of exclusive breastfeeding. This is shown to mitigate some of the effects of gestational diabetes mellitus exposure and have a protective effect on developing type 2 diabetes. The other aspect that is important is infant and childhood feeding practices. Many children who are born with a low birth weight are still being encouraged to show catch-up growth, but this is harmful. So it's important that the babies who are born small, continue on their birth weight centile, and we should discourage rapid catch-up growth. Overfeeding and force-feeding children are still very prevalent in our culture, but these are things which we should, as healthcare providers, discourage. And indeed, there's a lot of marketing of unhealthy foods to the children. And this is important. It's an important etiology. The social programming worsens the fetal programming. So really, ladies and gentlemen, I think we all have a part to play by educating and empowering our community. And we should really advocate for a healthy weight, diet, and lifestyle for the whole family so that the parents are also good role models for their children. And community and policy initiatives are obviously important when you consider the extent of the problem. So as healthcare providers, we also play a role in advocating for policy changes. Restricting unhealthy food and beverage marketing targeting children is very important, as well as contribution to food policies, urban planning for physical activity, and school-based programs. When we consider the impact of the social and fetal programming, we really need novel interventions for healthy behavioral change, and we all can contribute to making our nation more health and weight conscious. I had the privilege of being involved in the Chandi Mandi project, which was a school-based project for children in grades 1 and 2 in Sri Lanka, as part of a multi-stakeholder project, where we did a pilot study in 1,650 children from 4 schools in Colombo, and we developed a storybook, an age-appropriate storybook, and a sticker-based food diary, where the children were learned to be conscious of what they're eating by the self-monitoring food diary, sticker diary, and the class teachers discussed the impact of obesity and the importance of a healthy lifestyle by the methods of this storybook. And we were very happy with very high acceptance and acceptability reported after the study by parents and teachers. And we found a positive improvement in the food habits of these children a week after finishing the project. And this has been published. But what was more encouraging was 9 to 12 months after the study, we did a follow-up project, and we found that the improvement in food habits was actually sustained. So educating these very young children is actually, I think, the best way to move forward. So ladies and gentlemen, there are so many ways that we need to target this, be it infancy, childhood and adolescence, reproductive age, or pregnancy. And if you are interested, you can read more from this article which was published by us recently. And I urge all of you to see how you can contribute to these efforts. So in summary, childhood obesity is an urgent public health problem needing timely action. And I hope I have been able to emphasize the importance of early life nutrition, which plays a pivotal role in the obesity epidemic we are facing today. Given the multifactorial causes associated with childhood obesity, we need comprehensive intervention strategies to address the multiple factors which are contributing. And as physicians and healthcare providers, all of us play an essential role in guiding families who are under our care, as well as advocating for broader public health changes. Thank you very much.
Thank you, Professor Mundu, for that speech. If there are questions, we can leave toward the end of the symposium to discuss. Our next speaker is Dr. Dhammika Ratnayaka. He's the consultant nutrition physician, National Hospital Galle. If we go to the professional summary, with 16 years of medical experience, including a decade focused on advancing nutrition in Sri Lanka, Dr. Dhammika has proven expertise in the fields of nutrition in infants, children and elderly. He is currently attached to the National Hospital Galle as a consultant nutrition physician and formerly as a fellow in clinical nutrition at the Upper GI and Bariatric Surgical Unit, Derryford Hospital, Plymouth, UK. He has also worked in intestinal failure unit of the University Hospital, Southampton, UK. So as the second speaker of this today's symposium, I would warmly invite Dr. Dhammika Ratnayaka to the podium. Over to you.
Thank you very much. Sorry. Thank you very much for the kind introduction. Today my topic is nutrition in elderly. If I go to the objectives, during the next 20 minutes I am going to discuss about demography of aging population, challenges with aging population, aging and malnutrition, nutritional intervention, importance of protein, vitamin D, calcium and sarcopenia. A lot of information within 20 minutes. I will try to cover as much as possible. What is older person? Who is older person? What definition of elderly person? According to the WHO, an older person is defined by a person who is over 60 years of age. In some institutions, some societies, that is described as over 65. That is, we can interchangeably, we are using both cutoff points. In 2030, 1 in 6 people in the world will be aged over 60. Not only that, in 2050, the 16% of the world population will be in this category. If we look at this graph, you can see that we have they are comparing under 5, that means children population, with older population. In 2018, that is, the both population are same, the number of person. But few decades ago, that under 5 children, they're much higher than the elderly people. But in 2050, the elderly population exceeds the children, under 5 children population. And why this is important? What are the challenges with these elderly people? Because of they are suffering from number of health conditions. So healthcare cost is very high. And economic impact, they are not working, so they are not involved with the gross national productions. And some of them need pension schemes. And they need some sort of social protection from government or private institutions. And government should provide special facilities for them. For an example, they need access, wheelchair access for government institution, private institution, hospitals, sometimes home level. So government has to provide some special facilities. All these need, we have to, public funds should be expended. And if you are talking about medical conditions associated with aging, there are a number of health conditions, change in hearing, vision, mental state, cardiovascular changes, memory, cognitive functions, nervous system, taste and smell, musculoskeletal issues, and body composition. Elderly person may be suffering from one or several conditions at the same time. When aging is okay, but aging is associated with diseases, it can cause disability. That's the problem we are having. So when patient is disabled, they need support from others. They are not independent anymore. What are the nutritional conditions associated with aging? If we take a healthy person, with the normal aging process, they can get primary sarcopenia. Sarcopenia is losing muscles. After the age of 40, everyone is losing muscles. Not only that, when aging associated with disease conditions, it can cause chronic inflammation. Because of that, also they are losing muscles. That's called secondary sarcopenia. When both conditions can be aggravated by malnutrition, especially protein, calcium, and vitamin D deficiency, and lack of physical activities as well. Altogether, primary sarcopenia, secondary sarcopenia, and malnutrition can cause frailty. What is frailty? Frailty is physiological decline characterized by marked vulnerability to adverse health outcome. So, patient become disabled. What are the causes for malnutrition? Sorry for this busy slide. So there are 100 of causes for malnutrition, but if we categorize them, there are 3 immediate causes for malnutrition: low intake, high requirement, reduced nutrient bioavailability. And under these 3 categories, there are, most of the time there are, other causes can be categorized into something like symptoms, that taste changes, dysphagia, etc. And beyond that also, there are a lot of causes. If I test few of them, medications, cancer, dry mouth, poor quality of care, like that. And all of these conditions are supported with low education, old age, polypharmacy, anorexia with aging, like that. So, like that, there are 100 of causes behind malnutrition in aging. So, you can understand malnutrition is very, very important in this population. Then, how can we detect malnutrition? So, we can screen for them. According to the ESPEN, European Society for Parenteral and Enteral Nutrition, malnutrition can be detected by 3 types of screening tools: MUST, NRS 2002, and MNA. What is MUST? MUST is universal malnutrition universal screening tool. Other one is, the middle one is nutrition screening tool 2002. The third one is mini nutrition assessment. We can use all 3 tools, but the MN is much better than other 2 because that's especially prepared for elderly population. In the MUST screening tool, we are using the person's food intake, BMI, weight loss, and the patient's mobility. By using all these things, we can decide whether this person is having malnutrition or at risk of malnutrition. If we are giving, according to the scoring system, if the score is below 7, then directly we can say this person is malnourished. Not only that, after the screening, then we should come to a nutrition assessment. Assessment is like other medical consultation. So we should take the history and we should perform examination and the relevant investigations. Then we can come to a diagnosis. We can say that whether this person is having moderate malnutrition, severe malnutrition, iron deficiency anemia, vitamin deficiencies, like that. Then we should give nutrition intervention, which should be followed by monitoring. Not only that, even after monitoring, then we have to reassess the patient to ensure that the problem is over. As nutrition intervention, what can we do? First thing is we have to calculate the person's energy and protein requirement. All are based on disease conditions and weight. So we should find the gap between what patient needs and what patient is taking. Then we should decide the route, that what route can be used for provision of nutrition. So always we try to use oral route to give normal food. And if patient is taking orally but intake is not adequate, we can do some changes in his normal diet. If that is also not working, we can consider about food fortification. This is not normal food fortification like industrial level. This is adding something extra, something rich with protein or rich with energy to his normal diet. Sometimes that also not working. Then what is the next option? Adding ONS, oral nutrition supplement. That is commercially produced nutrition supplement coming as powder form, liquid form. And we can add oral nutrition supplement to normal diet. And sometimes that also not working. Then we have to think about enteral nutrition, provision of nutrition through a tube, maybe PEG tube or NG tube. Sometimes that also not working. Then what is the next option? Then we can use supplementary parenteral nutrition. That means we are filling the gap using parenteral nutrition. Very rarely we can't use enteral nutrition. GI tract is not working, we can't use GI tract. Then patient need total nutrition through parenteral nutrition. That is called total parenteral nutrition. So, what are the alterations we can do if patient is eating and drinking? We can add some energy dense food like bread, string hoppers, milk, biscuits, and if patient is taking less amount of protein, we can add some meat, more fish, more egg, more milk. And energy dense snacks in between main meals, sandwich, cookies, cake, curd. And also food fortification, as I told you previously, we can add milk to soup or other food items. We can add some whey protein to his normal diet, adding butter or margarine to his normal meal. What are the energy dense normal Sri Lankan food? Here I have shown some pictures of some of our popular food, bread and butter, string hoppers with sambal, and three posher, and custard, and lavaria, and milkshake, curd, and avocado. So we can consider about this kind of thing to increase the energy and protein intake for this population. And food fortification. What can we add for the food fortification? We can add some whey protein to his diet if protein intake is very low. We can add some milk to soup. We can add some butter or margarine to his normal diet. We can add more coconut oil, coconut milk for the diet. So by doing these things, we can increase the protein and energy intake for this population. Normally we are telling rice kanji, the pulses, kolakanda, and healthy diet is all, we are always recommending this kind of thing. But in this population, these things not suitable because they have less energy. If you take rice kanji 1 cup, that will give around 40 kilocalorie. If you take 1 cup of pulses, that will give around 50 kilocalorie. And 1 glass of kolakanda will give around 50-60 kilocalories. And healthy plate, in healthy plate we are encouraging more vegetable, less rice. But in this population, if we give this plate to a person, elderly person with loss of appetite or malnourished, then we are worsening we are aggravating the situation. So instead of that, we can go for bread, which is high in calorie with butter and energy dense snacks. And I have shown here milk rice with lunumiris, because that is very, very important because of this population. They might have taste changes, so they like this kind of thing. And adding something they like here onion sambal with a lot of rice. So even though these are not healthy, we can go for these kind of option to increase energy and protein intake. And this, I have shown some protein supplement. These are not available in Sri Lanka, so I am not anything about publishing this no name and the things. So the oral nutrient supplement coming in both powder form and liquid forms. So they are rich in, some are rich in energy, some are rich in protein, some are in both. So we can use them accordingly to fulfill the energy and protein gap in this population. Now we should talk about protein. The normal person's protein requirement is around 0.8 to 1 gram per kg. For an example, a 60-year-old normal adult need around 60 gram of protein. Then what about elderly population? But they need more protein. There's a big range, the 1.2 to 1.5, because they are suffering from a lot of number of diseases, and there are other factors as well. I will show in next slide. Why they need more protein? They have anabolic resistance. What is anabolic resistance? They need more amino acid to produce protein within the body, not like normal adult. And they have low postprandial amino acid concentration in the blood. That means maybe absorption is poor, maybe digestion is poor, and their muscle perfusion also low. So if we need 10 gram of amino acid to a specific muscle, they need 15 gram of amino acid to that same muscle. And sarcopenia, their muscle, again sarcopenia is losing muscles, they are suffering from sarcopenia as well. And disease related protein catabolism. Because of chronic disease, they get chronic inflammation, so because of that, their protein catabolism also very high, so their need is very high. What are the consequences of low protein intake? When protein intake is low, your muscles will be broken down to take amino acid, so leading to negative nitrogen balance. It can cause primary sarcopenia, again secondary sarcopenia, frailty, and disability. Here I have shown the normal protein intake in a normal Sri Lankan person through typical Sri Lankan diet. I can't read all the things. If you go to that chart, you can see I have shown the normal food and beverages. Through that, normally they are taking, Sri Lankans are taking around this much of protein, 36 gram of protein. But if this person is over 65 or 60, that person at least need 1.2 gram of protein. 1.2, if assume that person's weight is 60, 1.2 into 60 is 72. That person needs 72 gram of protein, but normal intake is 36, that is around 50% of the requirement. What is happening if the requirement is low? Your muscles will be broken down, then you feel weak, sarcopenia, frailty, and need more support from family and the society and the government. Here I have shown muscle strength with the time for a normal person. Even after 40, usually after 40 we are losing our muscle strength and muscle quantity and strength, that function and the quantity. And the next slide also I have shown the same thing. They have measured hand grip strength. Hand grip strength means the strength of these small muscles in our hand. That also in both male and females, the peak muscle strength can be, hand grip strength can be seen around 30-35. After that we are losing. Then how we can, okay, I will describe that how we can preserve muscle function in next slide. Here I have shown the relationship between sarcopenia and the protein intake according to this study. The sarcopenia is very significantly seen in a group in which protein intake is significantly low. So how to preserve our muscle mass? That means how to prepare for elderly life? Adequate energy intake. You can give high protein like 2 gram, 2.5 gram, but at the same time we should give adequate energy. If not, the extra protein we are giving will be broken down for energy. Adequate energy and adequate protein, regular exercise. If we can combine resistance training exercise with adequate protein and energy, that would be the best thing to preserve our muscle mass. This is a recommendation given by the American College of Sport Nutrition. I can't read all these things. According to that, we have to engage in resistant exercise at least 2 to 3 days a week, for at least covering 6 groups of muscles, 2 to 3 sets, 8 to 12 repetitions, like that. That is very, very important. That will give a lot of benefits for our muscles, quantity, functions, blood glucose, controlling blood glucose, hormone balances, like that. And the next topic is calcium. Why calcium is important? Calcium is very important for our muscles and our bones. There are other benefits as well. So normally we are taking our calcium from our diet, dairy products, and then the non-dairy products. If we are taking our total requirement from these two, then we can consider about taking supplement. Normal average adult need around 1000 milligram of calcium. In elderly it can go up to 1.2 gram of calcium. Again, I have shown the normal calcium intake in Sri Lankan diet, from Sri Lankan diet. We need around 1000 milligram of 1 gram of calcium, but if you go through this diet, typical Sri Lankan diet, we are taking around 500 milligram of diet. That is again 50% of the requirement. But if we manage carefully, if we add calcium-rich food to our diet, definitely we can give the total requirement. And the next important thing is vitamin D, because that also very important for our bones and muscles, and especially prevention of osteoporosis. So unfortunately, vitamin D is very low in our normal diet. A normal person need around 600 international unit of vitamin D. In elderly, again, it goes up. They need around 800 international unit of vitamin D. Unfortunately, free food naturally contain vitamin D. Dermal stins is the main source of vitamin D. Subclinical vitamin D deficiency is very common. This is the vitamin D production pathway. You already know about this. Here also I have mentioned skin production of vitamin D in the skin, which is the most important part. And how can we address, how can we overcome, or how can we prevent vitamin D deficiency? Easily what we can do is exposing to sunlight between 10 a.m. and 4 p.m. How many days? At least minimum 2 days, twice a week. Then we can get our vitamin, we can fulfill our vitamin D requirement. Summary: malnutrition and sarcopenia are significant issues in elderly, which should be addressed properly. Protein requirement is high in elderly. Adequate protein, calcium, vitamin D, and physical activities are important in elderly life. Thank you.
Thank you very much, Dr. Ratnayaka. We would be taking up questions at the end of the 3 presentations. Our next speaker is Dr. Manilka Sumanathilaka, MBBS, MD, MRCP Diabetes Endocrinology, FRCP, FSCE USA, SLCE Sri Lanka, and FCCP. He is a consultant neurologist working at the National Hospital of Sri Lanka. He was the President Diabetes Association of Sri Lanka, former Chairman of Sri Lanka Diabetes Foundation, past Vice President of Sri Lanka Medical Association, past President of Sri Lanka College of Endocrinologists, former Secretary of South Asian Federation of Endocrine Societies. He has done so much of other workshops and training programs in endocrinology at the National Hospital as well as at international fora. and he has received President's Award for Scientific Research in 2020. On top of all these merits, he would be the President of the Sri Lanka Medical Association in 2026. So Manilka is not anyone new to the SLMA or to the medical profession here in Sri Lanka. So let me invite Dr. Manilka Somanathilaka to talk to us on the critical role of nutrition in diabetes.
Thank you very much for the kind words of introduction and getting me an honorary fold in your area. You said neurologists is fine. They are so used to it. And okay, so thank you very much SLMA and the Gaul Medical Association for this kind invitation. I think Sumudu and Dhammika has made my speech easier because diabetes is a disease from the womb to the tomb. So the two ends of the spectrum has been tackled. So I have to do what needed to be done in the middle. So as you know, it's a global, I would say, a pandemic. The total diabetics now in the world has crossed the 500 million mark. It's 537 million as of last year when I checked the IDF Atlas. Maybe it's just crossing, and about 6 to 7 million deaths worldwide each year due to diabetes and its complications, which is more than the deaths of the COVID pandemic, which we unfortunately had. So it's a silent killer, lots of death, and the numbers are staggering even in Sri Lanka. This was the 2007 survey, we had 10.3. Now the STEP survey, the latest one showed 14.9, and another study showed 23% prevalence of diabetes, and a study done at the National Hospital in 2017 showed 27% prevalence in the Colombo area around the hospital. So it's anything between 15 to 25% according to the rural or town areas. I mean, we have seen why nutrition, how nutrition is important. I'll show you a few photographs. Sumudu attributed to the thrifty gene. So our genes are mainly hunter-gatherer genes. We have to really work hard for our food, and we get a moderate amount of food, and we tend to store whatever we get. But now things have changed. Do we have to go hunting or do farming to get our food and waste a lot of energy? No. Within half an hour, you can get even a month's supply of food from the supermarkets and the availability. And what do our children do? Like Sumudu attributed to the childhood obesity. And this is the root cause. Type 2 diabetes is becoming a lifestyle disease, and it's starting with the pregnancy and childhood mainly. Energy-dense food, lack of exercise and overeating and obesity, all contributing to the energy imbalance, which Sumudu has explained, so I can skip these slides. And this obesity and the diabetes, what we call as the pandemic of diabetes, sometimes people call it, or metabesity. So different words, but all have caused this pandemic of diabetes. Now coming to the management, it's going back to its root cause. So nutrition plays a pivotal role in the prevention and management, and even now the new buzzword in our circles, remission of diabetes. In all three settings, nutrition plays a very important role. And the traditional teaching, the management of diabetes, we always say 1 and 2 will be diet, exercise, then only the medication. The drugs also we have so many new drugs, but all these things will work only if you do the first two properly. So today we are talking about the first step. And we have to live according to our genes. I think that was explained again in the first speech. And eat according to our energy needs. So we can't say that my grandfather used to have a full 3 plates of rice and say that we are having the same amount of rice by spending less than half the energy what our grandparents did. So you need to eat according to your energy needs and lead an active lifestyle and prevent obesity if you want to, prevent diabetes and manage your diabetes well. And of course, we have to make our choices, teach the children and choose wisely. Everybody will agree which side that you have to choose. And Dhammika, the nutritionist, will explain further when you go to them. But generally, if you can follow the food pyramid, we have to take carbohydrates. You can't just eat only meat and manage diabetes. We have to take a certain amount of carbohydrates, good quality, high fiber, complex carbohydrates, not the fine, the high glycemic index carbohydrates or the refined carbs. And then certain amount of vegetables and fruits, and the proteins is very important, and little bit of oil is needed. So the WHO for the African region, they developed this Zimbabwe hand jive, which is a good, which I always use. You may have seen this slide before as well. Just to get the quantities in a practical way to the people. So fist, with your closed fist, both hands will be your amount of carbs and the fruits that you can take. With open arms, you can take whatever the amount you can take, the fiber-rich vegetables. The protein, roughly, Dhammika said 0.81 milligram, you can measure, but roughly size of your palm and thickness of your little finger should be your protein portion for a meal. And you can see the fat, amount of fat should be like the tip of your finger. So you can get the proportions here for a layperson. And of course, this might be more easier, the plate method. So this is from the Canadian Diabetes Association. There are different plates. So they say half the plate should be the good vegetables, 1/4 starch and or cereal, and 1/4 protein. How practical this would be sometimes. So I have compromised with my patients, of course, like Sri Lankans, it's impossible sometimes. Morning and breakfast and dinner, I insist on this 1/4 plate, but lunch sometimes we might have to go a little bit more. Like Dhammika said, they need the energy intake. They can't have so much of protein because of the cost and expenses. So you need to compromise. I would say half a plate or little less than half, and the other half vegetables and proteins, but never serve your vegetables on top of the rice. So that is the rule. Then you tend to eat more vegetables, although Dhammika didn't like this plate. So this is for not a malnourished person. This is for a type 2 diabetic, not so elderly. This is our recommended plate that we would like to show. So little bit more rice if you are 60 or above can be tolerated if you have any energy needs. But it's a simple balanced diet. You don't have to. There is no sort of rocket science here about a diabetic diet. It's just a simple balanced diet that we are talking about. Then your patients and everybody will ask different types of rice, white rice, nadu, tambapu, which is which, and this vegetable. So this all boils down to this, principle of glycemic index. So I have no time to explain all that, but the green ones, 55 or below, will be good for diabetes, 56 to 69 moderate, but the red ones are not so good. But there are practical implications. You look at, let's take, say, brown rice. It's a lower glycemic index. There are certain basmati varieties we can't recommend, it's so expensive. Low glycemic index, like 43, ones are there. But people say, I eat brown rice, and if you have 3 full plates, what happens? So it's all about the glycemic load. So the glycemic index is the quality or the amount of sugar that will go up with this particular food, but the load is the quantity that you are taking. So if you take a large quantity of a low glycemic index food, still the problem will be the same. So the glycemic load is very important and the quantity is very important. Even little bit of white rice, if you have a smaller quantity than the red rice, wouldn't be a problem actually, although we try to advocate, parboiled and red rice, all that. Even white rice, if you eat a very small quantity, rather than eating a full plate of red rice, it will be okay. And the watermelon, it's high, but if you eat a small piece, the load will be less. Similarly, bananas moderate, but if you take 2, 3 for a meal, then the load is going to be high. So this is what you have to tell your patients. But the killers or the biggest problem will be, as Sumudhu also mentioned, the snacks, and people think the in-between, the light meals that they are having, the snacks and all that. So I have, for political reasons, I have covered, and I hope I have uncovered enough for you to recognize what it is also. And so this was given to me by a nutrition colleague. They have actually measured, and the amount of sugar in each of those things. So it's much more than in a plate of rice, actually. So imagine the children having 2, 3 of these drinks for a day, or during their, interval, all that. So we need to tackle these things when it comes to the problem of managing diabetes and even preventing diabetes and obesity. I'm sure you all have seen this. The ministry has gazetted this, the traffic light system. So we must tell our patients and children, learn to read the food labels. And even no need to read the small print. The manufacturers make it, very small so that you won't be able to read. But at least this is mandatory now. The big marks will be there. From the color, you can recognize what it is and then choose wisely. So, ladies and gentlemen, when it comes to diabetes management, you have nutrition is very important. Number one step, I would say. And your dietary goals, we say, should be smart, simple, like I said, the plate method or from the hands, or, which is very easily done by anybody and with any level of education. And it should be measurable, like shown before, whatever the way you say, rice in teacup size or spoon sizes or whatever, simple measure, achievable for that person. So individualized treatment, you have to recognize the patient or the person and then give the ideal achievable goal. Somebody who is used to 3 times a day rice and who can't sleep at night without a plate of rice, you have to tackle that person in a different way rather than telling you have to have a salad and a soup for dinner and oats for breakfast won't work. He will just laugh and then will not come back to you, right? So it should be achievable, realistic in the current economic situation, social background, ability, age, all that, other comorbidities, all that should be considered when you are advising on diet. It should be realistic and time bound. I'm sure now after the December holidays and Christmas time, all of us will have New Year resolutions. This year I'm going to reduce, and by the Sinhala New Year, all gone. So we lose 4-5 kilos again, we are back to square one. So crash courses won't do. So whatever the little change you can, if you can make, reduce the amount of rice by 2 handfuls for a month or 2 months and maintain that for a long period, that will have a better effect than any crash courses. Some people, when they were diagnosed with diabetes, they say intermittent fasting, or they just fast. They don't have their dinner, just have 1 meal a day. Crash courses won't do. They regain that weight after some time. So coming to the next one, exercise. People who exercise say that I can eat because I do a lot of exercise, but not like this guy who is taking a shortcut, right? But for people who say I go to the gym and then I can eat whatever I want because I'm eating the normal diet, but I go and exercise. So this is the scale of things. I'm sorry I couldn't find this typical Sri Lankan food, but take the Coca-Cola can, 140 calories, 23 minutes of walking. So you can do the math and see the whole day we'll be exercising for the amount of food we take, sometimes with the snacks, if you want to burn by exercising. So a good diet, low calorie, low energy intake, combined with exercise will do good, but not just exercising without a good diet. So the Sri Lanka College of Endocrinologists, we have done a good app here for the patients. You can download this free and get an idea about the amount of carbs that's there in our local food items, and then you can get the scale of things when you eat, the amount of energy, all that can be done in an app which is freely downloadable. So please share among your patients, it will be very useful. And coming to the other part of this remission, something new, reversing diabetes, because saw the numbers, we just can't keep on treating them. Thousands of patients will be there and with lots of complications, so we should try to reverse this disease. So we have this ominous octet where the diabetes pathophysiology over the years have changed. I think when you and I were in medical school, other than the younger crowd here, we would have learned that diabetes, type 2 diabetes is due to either decreased production of insulin from the pancreas or increase in insulin resistance. Very simple, two things. But you can see there are 8 defects, mainly the fat in the liver, fat in the pancreas. So fat is everywhere. Obesity plays a crucial role in most of the pathophysiological defects other than in the kidneys and the muscle, everything. Fatty tissue is becoming an endocrine organ with so many hormones, including leptin, which is contributing to obesity and diabetes and other metabolic disorders. So with this, the Banting lecture came on the twin cycle theory of diabetes, where there is a liver cycle with positive calorie balance, increased liver, fat in the liver, fatty liver with increased insulin resistance in the liver, unchecked gluconeogenesis, hyperglycemia, and this high fat in the liver spills over in the form of VLDL and triglycerides into the pancreas, and there is evidence to say that increased islet triglycerides and fat deposited in the pancreas impairs the insulin release and causes again hyperglycemia, which is mainly postprandial. So this twin cycle is causing the main problem with type 2 diabetes, which we have found that is reversible. Roy Taylor did the main thing, so we call it as remission now officially. The definition is if you can reduce the HbA1c to 6.5% and maintain it for 3 months, and without any pharmacological intervention, you can say that somebody has gone into remission. So how do we achieve this? We should try, all of us should try, especially for our newly diagnosed overweight and obese diabetic patients. Roy Taylor did many studies. I don't have the time to tell you about all the studies, but the counterpoint and the counterbalance studies showed that a very low calorie diet, if you lose 15 kilograms or at least more than 10% of your body weight in obese people, you can reverse this fat in the liver and the pancreas. And that was proven in this study, which changed our approach to management of diabetes, called the DIRECT study. I would advise you to read on this study called the DIRECT study, which used a very low calorie diet, about 850 kilocalories a day for about 3 to 5 months. So these were the inclusion criteria within 6 years of diabetes. The cells don't die, beta cells don't die, they are just stunned by fat. So the reversal was possible within 6 years of diagnosis of diabetes in 27 to 45 BMI range. They were given 12 to 20 weeks of very, very low calorie diet in the form of nutrition supplements, 850 kilocalories a day, and let's see the results. 46% of all medications and remission in 1 year. 76% was of all medications, but they didn't meet the strict criteria of 6.5. And they lost weight by about 10 kilos average. This was even followed up for another year, 2 years, 36% still maintained on an isocalorie normal diet, which is, not very high, but they went back to their normal diet, not just supplement and very low calorie. And this was statistically significant. So it's very important that nutrition plays a pivotal role, and mind you, this was done in the primary care setting in UK. So this was done again in, this is the direct study which I tell you to read up in the interest of time. I have only about 1 more minute. And the diadem study was done in Qatar. So it's more relevant to the South Asian region. They also replicated the same results with the diadem study, showing that remission up to 61% of the patients at 12 months with a low calorie diet for 12 to 20 weeks only, and then maintain that weight loss of about 10 kilos for a year. And the MR spectroscopy shows how the liver fat has gone down after this intervention and the reversal of diabetes. So it's all linked to fatty liver and fatty pancreas. And ladies and gentlemen, I think this is a very viable option for us to do this nutritional intervention in a sort of a population approach for all our patients and try to reverse and minimize the problem of diabetes. Thank you very much.
Thank you, Manilka, for that nice presentation. I think we need all 3 speakers to the head table. We are actually 30 minutes late. We can have 1 or 2 questions.
It's been promoted by mainly commercial interests.
Yeah, thank you very much, sir. Very common question actually after the presentation. If you are doing our physical activities, especially resistance exercise regularly, that means 2 to 3 days a week as a professional, after going to gymnasium, something like that. So definitely that is very, very important. Taking 15 to 20 grams of whey protein just after workout or just before workout is really essential to improve the because of workout muscles get damaged. To settle that, to improve that, that's very, very important. For normal people, in elderly population, we can consider about that is because of if we can't give the total protein requirement from the diet, and if patient is very malnourished and patient is frail, then whey protein is very good. Otherwise, it's not needed. Yeah, for normal diet, actually that we don't need that one. For people who are engaged in physical activities like resistant activities and people who are malnourished, that is very, very important. That's very good.
Yes, so let me ask him about the same thing now. The diabetics, he showed very well that they are getting about 36 grams of protein in the normal diet. 72 is the requirement. So I just calculated you need 7 eggs for a day. So we say at least 1 whole egg and then 1 egg white. And it's not practical or economical to have 7 eggs, I suppose, for all the patients. So can diabetics also be supplemented with a whey protein? Is it cheaper than eggs, or what is the quality and the amount to match 7 eggs?
The problem is whey protein is really expensive, so definitely normal people can't afford it. So the thing is we should try to get the total requirement through our normal diet. Like we are promoting oral diet and enteral feeding, our first aim is to get the total requirement through our normal diet. For that we have a lot of resources. We have fish, dry fish, whole meso, and milk products like that. If we carefully plan our meal, definitely we can fulfill our requirement. If we can't, definitely we can go for options like that. Actually, its absorption is very high. That is produced from milk. The milk has whey part and the casein part. The benefit is whey absorption is very rapid, and it can rapidly go to the muscles. And muscle protein synthesis is much, when compared to the casein, the production efficiency is much better than casein.
My question is with regard to vitamin D and calcium. Now we see that more often we do vitamin D levels and prescribe vitamin D. Now have they got to all the time combine it with calcium, or, I mean, I see we prescribe vitamin D without calcium tablets. So do we have adequate calcium in our diet, or should it be combined with calcium?
I think reason behind that is the both deficiencies they're going together. When vitamin D is deficient, calcium also deficient in our diet. So I think that is more practical, giving both vitamin D and calcium together. If calcium is adequate, then we can give only the vitamin D.
For diabetics, of course, I would say measure the calcium levels. You know what, I would say measure the calcium levels, because if the person is having an adequate amount of calcium in the diet with vitamin D, they'll be absorbing the calcium better as well. And we have an issue about calcium deposition and, renal issues, and, excessive calcium is also not good for a diabetic, I would say, with a high cardiovascular risk. So what I do personally is first start the vitamin D, and then next visit check the calcium level. If that is low, give a supplement, but you have to monitor. You can't take for years, and every 6 months you should do the levels, because sometimes we see the levels go up and it just trickles into the urine as well, and so we have to have a balance. But vitamin D, of course, 1,000 to 2,000 won't cause any harm because our levels are so low. But still, I would recommend to do the levels at least once a year if you are supplementing.
And if I just include in pediatric practice also, if the child is, taking milk, then usually their calcium intake would be okay. So we are also a bit careful, because hypercalcemia can occur, especially when we are treating insufficiency or deficiency. We tend to give mega doses of vitamin D. So I also would check the calcium levels and only supplement if it is either the child is taking a calcium deficient diet or has hypocalcemia.
I think we have come to the end of the first symposium of the Foundation Sessions 2024, organized by GMA and SLMA. Now it's time to appreciate our speakers with certificates.
Thank you to our esteemed chairpersons and speakers for that truly enlightening session. Now I'd like to invite the chairpersons to present the certificates of appreciation to the speakers. Ladies and gentlemen, we now break for tea. Please reconvene at the auditorium in 15 minutes for the next session. Welcome back. To begin the next session, we are privileged to have Dr. Harsha Jayakodi, Acting Consultant in Health Informatics, who will deliver a guest lecture on AI in Health, the Way Forward.
Good morning, everyone. Actually, it's a pleasure to address this type of a group regarding AI. Just a small introduction about myself. I'm Dr. Harsha Jayakodi, and I'm working as an acting consultant in health informatics. And I work very closely with the WHO AI for Health group. So there are certain experience that I will bring in to show you today. So, as we all know that we stand at the crossroads of innovation, where artificial intelligence is reshaping how we think about health and healthcare delivery. And today we'll explore not only about AI and also about the way forward actually. So we'll just take a moment and think, what role do you see how AI will play in a country like Sri Lanka in healthcare in the next 5 or 6 years? Just imagine. So all of you are aware what is artificial intelligence. So artificial intelligence, if you just say it in a core, it's like about machines mimicking human intelligence. The beauty of AI lies in the ability to analyze vast amounts of data, learn from it and make decisions and also predictions. In healthcare could mean by diagnosing diseases and optimizing treatment plans and also predicting patients' outcomes. Just imagine a virtual assistant helping us to provide a better care, faster, smarter, and even more accurate. So, machine learning is a subset of AI where you train a machine to actually use data and improve the performance. It's like just training a new junior doctor, where you train more the doctor, his clinical skills can be improved. So machine learning is also like that, where you train with a lot of data, you make the learning more and more precise. And then we have something called deep learning also. So it is a broader family of machine learning actions, and it's actually in deep learning, machine learning is taken to the next level, where large number of algorithms are used and complex patterns are solved, and it makes highly understand. And deep learning is not just a science fiction, it is used now in most of the countries, especially in oncology, dermatology, and certain other mental health conditions too. So AI is already begun transforming the healthcare. So we see a lot of examples like in critical diseases where AI used for medical imaging. We'll just go through each of these. And there are AI-based chatbots actually for scheduling doctor appointments in certain countries, and then medication reminders, and even identify conditions based on symptoms. And there are, as you all know, AI-powered surgical robots actually, and machine learning applications provide certain certain surgeries. And also in AI is used in pharma industry, and also in lifestyle and nutrition management, where individuals' risks for lifestyle diseases is assessed, and customized recommendations can be given through these AI platforms. And also, as we spoke before, in mental health also, AI can be used. And also in the educational aspects, where in educational applications, AI being used, especially for simulations and also for adaptive learning. So let's see some examples in medical diagnostic. So as you all know, there are certain examples actually where artificial intelligence and machine learning is used in medical diagnosis. In pathology, it is used to diagnose diseases from laboratory test results, where automated algorithms are used to read certain laboratory test results and then summarize them. And in oncology and radiology, to recognize cancerous tissues, biopsies, and radiology evidence in images. I will show you some examples. And in dermatology and aesthetics, especially to diagnose certain skin disorders and typical lesions, and especially to do facial analysis on aesthetic purposes, AI is used. And in genetics, especially to diagnose disorders and rare diseases based on observed phenotypes. So as I spoke before, detecting of lung cancer in CT scans is now generally used. AI algorithms can analyze the chest CT scans to identify suspicious nodules actually, and lesions that might indicate certain early stage of cancer, which the human eye may not be able to detect. So we can train a machine to learn these things and then to help in decision support, especially for radiologists, to diagnose easily and very precisely. And these algorithms can flag potentially concerning areas where radiologists can review more closely, and it will actually save more and more lives. And in diabetic retinopathy, especially in ophthalmology, AI can analyze retinal images to identify signs of diabetic retinopathy, which is a complication of diabetes. And here the doctor, even no need to stay at the same place, doctor can stay thousands or 2,000 kilometers away, and if the image can be passed properly and read by the AI, then the decision support can be made very easily. And more diabetic retinopathy can be detected, especially in low income countries. There's a lot of good that can happen by this type of AI driven certain applications. And even AI algorithms can assess the severity of the condition and recommend appropriate treatment. And this is an actual picture which I took when I visited University of Helsinki with some WHO representatives. Here in their pathology department, they actually use these AI models to detect especially breast cancer, certain cells, and then these ML models are actually trained especially to detect this from histopathology slides. And this can help the pathologists to focus their attentions on the areas which needs close examination and aid faster and more accurate diagnosis. And in tumor grading and prognosis also AI we use. AI algorithms can analyze the tissue samples from cancer patients to determine grade and the aggressiveness of the tumors. So this is also used, these are also used in certain universities. And in genetic disorders, as I mentioned before, AI can analyze genomic data to identify patterns associated with rare genetic disorders. And by comparing with a patient's genetic and with the databases known as genetic mutations, and then you can assess and help for a better decision support. And there are certain other instances where in cardiac diseases for ECG analysis, for decision support, this type of things are used. And in early detections of Alzheimer's disease, especially by using certain wearables where Alzheimer's patients can be aided, and also through PET scans and MRI scans by training certain ML algorithms, these can be detected early. And as I spoke before, for skin CA and melanoma detection also, it is used. And we'll see now what is AI used in treatment. Especially for personalized treatment plans, AI is being used. As we know, the traditional medicine often adopts generalized approach, treating patients based on averages. So each individual's genetic makeup, medical history and lifestyle contribute to their unique health profile. So embracing personalized treatment plans is crucial in the future. So by using certain AI models, the patient's genetic predisposition and optimizing the effectiveness can be made by minimizing adverse reactions by personalizing the treatment. And also by considering the patient's medical history, we can design certain treatments that align with the patient's specific needs through these AI models. And as you all know, we also use certain wearables where a lot of data is being gathered, but this data is not used properly. So if our heart rate and sleep patterns, physical activities can be gathered and then analyzed, the healthcare professionals can specially create personalized treatment plans. And there are certain telemedicine applications even in Sri Lanka where personalized data is gathered through. Now all of us are wearing sometimes Apple Watch to create certain personalized plans. And especially people with busy schedules, through this type of tailoring dietary recommendations, more holistic approach can be made. And also AI algorithms can create more personalized treatment plans to increase the patient's outcomes and prevent certain diseases in the future, and to reduce the healthcare cost for people. And these are few studies actually which are done in AI-based personalized treatments. And if we talk about the benefits as a summary, speed and efficiency is a important thing where AI will bring out. And then data-driven insights, because there are a lot of data gathering points, and data is gathered through certain devices, certain wearables. So there are a lot of insights that can be made through these AI models. And then it can enhance the diagnosis accuracy and also enhance the decision making, especially decision support is what matters actually when we treat a patient. So by using these AI models. And there are certain ethical and regulatory considerations. So especially patient-sensitive medical data is there. So there should be certain things to protect patients' sensitive data, and proper measures need to be taken to prevent data breaches and unauthorized access, because a lot of data, AI is playing with a lot of data. And patients should understand the role of AI and how the data will be used beforehand before using these type of devices or using any apps or engaging in any AI sort of things. The patient understanding is also very important. And this AI algorithm should be transparent. It is very important where it should not be like a black box where you can't see. So then it is very important where you can improve more and more in the future. And then when it comes to AI, there are a lot of bias happening, because the data used in this type of models, their data bias can be happen. So the WHO is working very much on this data bias things, and also there should be proper regulations like FDA approvals for these type of apps or devices. And always there are challenges and limitations. So when it comes to challenges, especially countries like Sri Lanka, there are a lot of challenges that we will have to face. And IT literacy is one, then internet connectivity is another one. And when it comes to data, the quality of data is also very challengeable. And in certain countries like India, where a lot of different type of people live with their ethnicity, and you have very vast diversity, so there are a lot of data can be different in certain areas gathered, so then the solutions may need to have a lot of data from all these diversified people. And then complex AI models often lack transparency, as I told, in decision making, so it requires adapting to new transparency, especially when you're using what is actually happening here. So it should be even a lay person should be able to understand this is the basis of this, and especially when it comes to legal, who is going to hold the responsibility for medical malpractices committed by AI models. That is a very much concern. And the future possibilities, I think most of the things I have mentioned before, the robotic assisted surgeries and then remote patient monitoring, which will be very useful in elderly patients, where AI powered wearable devices can continuously monitor patients, their vital signs and health metrics, allowing for early detection of certain health issues, alarming and providing real-time feedback to healthcare providers. And then EHRs, electronic health records. So AI can extract the valuable insights from these EHRs and help clinicians make certain decisions, especially identify the trends and predict patients' outcomes and suggesting personalized treatment, as I mentioned before. And mental health support is also important aspect of this AI health devices, and AI health driven chatbots are used as virtual assistants which can offer immediate support and resources for individuals dealing with mental health issues and supplementing traditional therapeutic approaches. And as my personal experience, there are certain AI use certain apps in Sri Lanka where it is in very primitive state, but there are a lot of university students who are engaged in this type of AI applications, and also there are certain apps using AI in telemedicine, as I mentioned. So regulation is also must, especially because we are dealing with people's health and sensitive data. So there should be proper regulation also. And the adoption of AI isn't without hurdles. As I mentioned, the high quality data is crucial for AI-driven apps. And the future, especially in countries like Sri Lanka, we will have to properly regularize these apps and then see what are the benefits that will happen without just adopting each and everything. And I will just show you one slide where which I found in internet actually, where this in King Ravana is one of the powerful according to myths, and then where there are certain prehistoric, if you just read, you can just find out there are certain things related to Ravana also with this machine learning. And so I would just tell a few words about the Expert Committee on Artificial Intelligence in Medicine in Sri Lanka Medical Association. So we are a group of doctors. We actually formed it last year, and this year, and we would like if you all also can join this committee. We hope to do more and more workshops and certain other lecture series in the future. So thank you very much. If you have any questions, you can ask. Thank you.
Please remain on stage. Thank you, Dr. Jakodi, for your fascinating insights into the future of healthcare. Now, I'd like to invite Dr. Vimala Sirulwathage, President of the Gold Medical Association, to present the Certificate of Appreciation to Dr. Harsha Jakodi. Next, we have second symposium titled The Invisible Enemy, Infectious Diseases and Beyond. To chair this session, I'd like to invite Dr. Sarath Gaminidi Silva, Senior Consultant Physician, and Professor Ajit Nagahavatta, Professor of Microbiology, Faculty of Medicine, University of Ruhuna, to the stage.
Good afternoon, everyone. Let's start the symposium number 2, The Invisible Enemy, Infectious Diseases and Beyond. Let's start with Dr. Bhagya Piyasiri, who will speak to us on the mystery mimicker melioidosis. Yeah. Now, excuse me, yeah. Now, Dr. Bhagya Piesari is a consultant clinical microbiologist and the head of Department of Microbiology and Infectious Control and Prevention in the National Hospital, Galle. And he had been here from 2014, that's for a period of 10 years up to now. And he holds the postgraduate coordinator of the Executive Committee of the Galle Medical Association Council this year, and a member of the Melioidosis Combined Working Group of the Ministry of Health and Epidemiology. Dr. Bhagya Piesari, please.
Thank you very much, sir, for the kind introduction. Good morning, dear all. It's good afternoon. So this is, thank you for the opportunity given by the organizers to talk on my pet topic, Mystery Mimica melioidosis. So this is my overview. So melioidosis is caused by, everybody knows, that is Burkholderia pseudomallei. It's an opportunistic pathogen. Endemic in Malaysia, Thailand, Singapore and Australia. Sri Lanka is also considered as an endemic country now with the increase in cases. And mostly affects the high-risk groups with diabetic, CKD, COPD, smoking, steroids, thalassemia, likewise. So Sri Lanka, one of the first countries to report melioidosis back in 1927. So case of a fatal melioidosis in a European tree boker, resident in Sri Lanka. But after that, actually, there were no reports until very recent because of the limited surveillance. National surveillance started in 2008. So how this is spread? Via inoculation, inhalation or ingestion. Usually the incubation period is 1 to 21 days, median 4 days, but in certain less than 5% cases, it can be months or years sometimes. This is how our people recorded their exposure to mud, soil or water. You can see mostly they are farmers, manual workers, gardening, flooding, sand loading were there, and some fishermen. Soldiers who fought in the war front, carpenters, masons, and some tsunami victims were there, and near drowning cases were also there. So this is the Galle database started back in 2014, 10 years back when I came in here for the first time as a consultant. Now we have 102 culture positives and more than 55 serological positives. What is the rule of diagnosis? It is need to suspect on clinical grounds before any culture or serology, especially with our rising leptospirosis and tuberculosis. This is how we diagnose with the cultures, mostly blood, pus, multiple, or sputum, bile, joint fluid, CSF or urine. And this is the culture, the pictures of cultures with the typical ABST. And in our database, the people were mostly from Galle district and some were from Matara and Hambantota, few from outside the province. And you can see in the graph the number of cases getting increased year by year. 2014 is the most notorious year. Up to now, we have had more than 20 culture positives this year, the highest number in the decade. And how this is the right corner one, the lower down, shows thus the seasonal variation, and it tallies very well with the rainfall of the district. Prevalence of diabetes is about 75% and other comorbidities were there. So the clinical presentation, acute presentation is around 88%, chronic 9%, and there can be latent or reactivation. So almost all the systems can be affected. Why is it called a mystery mimicker? So what is our clinical experience? Now this is how our people were presented with pneumonia, abscesses, septic arthritis, central nervous system pathology, pyelonephritis, endocarditis. And we'll talk about respiratory manifestations, mimicking leptospirosis. 65-year-old farmer from Alpetia, no history of diabetes, alcoholic, hypertension, fever for 3 days, body aches, developed shortness of breath, hypotensive on admission, WBC was 21,000, platelet 89,000, CRP 24. Serum creatinine was very high, 487. So what is your clinical diagnosis on admission? It could be, the picture is exactly similar to leptospirosis. So that's what exactly happened. Treated as leptospirosis sepsis, started on ceftriaxone, fluid resuscitation, and hemodynamics he was not improved, so he was transferred to ICU. Lepto antibodies were not there at that time. What happened? Our system is actually, whenever a lepto-suspected patient is admitted to the ICU, I have requested to send a blood culture. This patient also had a blood culture on admission, and within 24 hours, less than 48 hours, it became positive for Burkholder pseudomegaly. So patient was started on meropenem, but with multi-organ failure, unfortunately he succumbed after 1 week in ICU. How it mimics tuberculosis. It's a 73-year-old female, diabetes, investigated for fever, cough for 1 month with pleural effusion. So CRP was 260 with ESR 115. So the working diagnosis was more or less TB. She was started on IV ceftriaxone for any superadded infection. Sputum AFB was sent, and the pleural aspiration was sent to us. It grew Burkholder pseudomegaly. TB PCR was negative. And meropenem was started, blood culture requested, it also grew the same thing. Melioidosis antibodies are 1 in 160 and treated for 2 weeks with IV and was discharged to clinic. So how can we differentiate? Is there a way of differentiating between melioidosis and TB? The literature says so, but it's a great mimicker, you can't forget it. Tuberculosis is more or less subacute to chronic, and melioidosis is acute to chronic with septic shock. In melioidosis, lymph nodes have a clear border, little contrast enhancement, and it could be uniform, not like TB. In TB, the lymph nodes may be calcified. And melioidosis is more towards absence of effusions or adenopathy. But previous history, you saw that the patient was having effusion. And in tuberculosis, matted nodes of low density with peripheral enhancement can be there. Melioidosis, hypoechoic, that is abscess, less rim enhancement can be there. So what are the other varieties of respiratory symptoms? This is a mushroom gardener, a diabetes, came with cough and fever for 2 weeks, and the X-ray was just mimicking TB. But TB PCR AFB were negative. We treated with ceftriaxone and doxycycline. There was no response. And we investigated for melioidosis, and the titer came as 1 in 320. So this is not culture positive, this is only the serology. But she responded very well. So this is how the X-rays were showing. Initial X-rays, and the last one, when she was discharged from the clinic after the dedication treatment. And case 4, diabetic, 47 years old, with pleural effusion. It was an encysted pleural effusion. We aspirated and it grew pseudomegaly. So he was nicely responding. The last X-ray was showing clearance. And near drowning. Near drowning also, if the patient is coming with pneumonia, you may need to think of melioidosis. A 65-year-old previously healthy male, he was actually drunken and he was riding his bike. He was crashed against a lamppost, thrown into a drainage, aspirated, and he came back with pneumonia. That culture grew melioidosis, the pseudomegaly. A 19-year-old previously healthy young male, again a near drowning case. After 1 week of the episode, he came back with pneumonia and the blood culture grew pseudomegaly. So what were the cardiovascular manifestations? This is a case of infective endocarditis, maybe the first and the only case reported from Sri Lanka. 73-year-old COPD ex-smoker, and there was a murmur, blood culture grew Burkholder pseudomalley. There were multiple small vegetations attached to the aortic valve and with mitral and aortic regurgitation. But the titer was, melioidosis antibody titer was 1 in 40. So this was published in CMJ. There's another endocarditis case I have not listed here, and there was a mycotic aneurysm case, 66-year-old retired security officer, diabetic, and he came in with absent pulse in right lower limb, and large saccular aneurysm was there in the right common iliac artery. Blood culture, and he was operated. Both blood culture and the aneurysm wall culture grew Burkholder pseudomalley. He was treated and he was successfully treated. So this was with the other case of mycotic aneurysm. This was published in the CMJ again. What were the neurological manifestations? There's a case of transverse myelitis. 11-year-old previously healthy girl complained of muscle pain, bilateral lower limb for 5 days, and difficulty in walking for 1 day, mild fever on day 3 of illness, left lower limb numbness for 3 days, and accompanying headache and back pain. WBC was normal, platelets was 343,000, CRP less than 5 on admission, creatinine was 44, ESR was just 25. MRI was showing transverse myelitis involving the distal spinal cord from T8. You can see the pictures hopefully. And AMA, aquaporin 4, emoji antibody, mycoplasma, TB, COVID, all negative. So the impression was idiopathic. She was given steroids, plasmapheresis, and IVIG. Then the LP done. What was the LP? Protein 98. Glucose, there was a sugar difference, and polymorphs 100. So the picture changed. Then, anyway, she was on ceftriaxone from the cefotaxime from the since on admission, but she was spiking fever. Then CSF culture grew Burkholder pseudomalley. Patient was treated for 4 weeks. The moment we started on meropenem and cotrimoxazole, fever went down and 4 weeks and was discharged to rehabilitation on eradication phase. There was a case of meningitis just last month, 2 weeks back. 47-year-old farmer, diabetic, alcoholic, fever for 3 days, dyspneic, ataxic, 1 day, managed at meningitis and NCCT showing ICH on admission. So on admission, we had 3 DDs. One was listeriosis, melioidosis, or whether it could be TB. So we investigated for all. On admission, we started on ceftriaxone and ampicillin because of the previous experience with the people with ICH. WBC was 9.2, platelets 104 low, CRP less than 5 on admission, ESR was just 13, creatinine was 102. There was ongoing fever, so on the day 2 of ICU admission, we started on meropenem just to cover the broad spectrum. And LP done, it was kind of positive, and initial blood culture was growing enterococcus. So we didn't know from where it was coming, and we added vancomycin. Anyway, this is a blood culture, we couldn't ignore. What happened? Then the fever was persistent, going into multi-organ failure with CRP rising to 205. WBC was 42,000. Then the melioidosis antibodies came after 5 days, 640. So we started immediately cotrimoxazole. So he was on meropenem and cotrimoxazole. Fever was nicely responding, but patient was really bad. Repeat blood culture grew Burkholder pseudomalley, but on the same day, patient succumbed, unfortunately, after 2 weeks of ICU care. So this is our outcome. Death within 24 hours, 8, and death during treatment, 12. So altogether, we had 20 deaths of these 102 culture positives, and 3 deaths out of 55 seropositives. So more or less 20% case fatality rate. What were the goals of management? Management of acute infection, remove the focus, management and control of comorbidities, eradication of the organism to prevent relapses, attain late onset complications during eradication period and follow-up, management of adverse effects of the drugs should be there, and ensure patient well-being, management of comorbidities, nutrition and rehabilitation. So some figures of our follow-up. We recruited about 128 patients since 2014 to our melioidosis clinic, and number successfully followed up was 116, that means more or less 90%. Adverse effects of the drugs and drug adjustments were there for 18 people. Deaths during follow-up, known cases were there for 3. Relapses, 7 relapses were noted, and some complications were. The one patient developed foot drop during eradication phase, which can be a complication of the inflammation. So how to address the adverse effects of the antibiotics, how to avoid? We give sometimes drug holidays of Cotrim or we temporarily withhold some drugs and we give drug holidays. Once the biochemicals are back in normal, we restart. And folic acid supplement is given. We avoid concomitant use of potentially interacting drugs if possible. So take home message, whatever the clinical presentation, melioidosis is a disease where a patient can be saved and quality of life improved with close follow-up, addressing individual needs and care. But you need to have a very high index of suspicion because it's a great mimicker. So I am really grateful to the organizers of this session and my teams, laboratory and infection control, my friends who helped, especially Dr. Ishan Jayasekara, who helped me a lot in this presentation, and the clinical laboratory staff of National Hospital, Galle and Faculty of Medicine, Colombo. They are the people who are doing confirmatory tests to confirm melioidosis cultures, and my family. So last year, we did a SLMA, I am a member of the Communicable Diseases Committee of SLMA, and we did an awareness program of melioidosis to raise awareness during the rainy season. And we introduced the local term. If you tell melioidosis, the lay people will not understand what is melioidosis, right? So we need to tell them in their language. So we introduced the term Panshu Una, soil fever. So they understand. So it reduces the stigmata. They think that it be TB, it can spread from person to person. No, now they know that it can be spread from the water, soil, mud. It doesn't spread from person to person. So there's a lot of stigmata is gone because of the introduction of new term. So that's it. Thank you very much.
Thank you, Dr. Piyaziri. We will have all the questions at the end of the 3 speakers' presentations. Next speaker is Dr. Vimalasiri Uluattage, who doesn't need any introduction to this audience now. Anyway, he is the president of the Galle Medical Association and currently the convener of Infectious Disease Forum of the Ceylon College of Physicians. And he is a consultant physician of National Hospital Galle, and he has been involved in organizing the first international ID conference in collaboration with the ISID in 2023. Over to you, Dr. Vimalasiri.
Thank you, sir. Thank you, Chairperson, sir. My topic is leptospirosis, rise in death toll and dissecting causes. Outline of my talk would be the impact. I'm going to discuss something about the impact of leptospirosis globally and at home, and the rise of leptospirosis, and I'm going to talk about something about the change in clinical pattern and something of leptospirosis pulmonary hemorrhage syndrome and its features and how to manage, and something about the future activities. Leptospira infect more than 1 million people around the world and causes 60,000 deaths. And great majority of these deaths occur in tropical regions and in the poorest countries in the world. Tropics account for nearly 73% of the world's estimated cases. Highest incidence found in the tropical islands like ours. An urban and slum environment are an emerging and increasingly important setting for the leptospirosis transmission. Nearly 50% of deaths occur in economically productive, especially in male between 20 and 49 years of age. So this is the map of world map of leptospirosis. You can see that tropical and subtropical countries are mainly affected, and you can see Sri Lanka is in dark red, indicating that it's a highly endemic country. What about the situation at home? From the 2015, we have been reporting ever increasing numbers of leptospirosis, and last year reported the highest number of nearly 10,000 cases of leptospirosis. And what are the deaths? Again, same trend, increasing number of deaths reported over the years, and last year reported more than 200 deaths. So what are the reasons why this infection is increasing and causing a lot of havoc in our society? It's mainly due to 4 factors: environmental factors, reservoir host, and the host factor, that is human, and the pathogen. All these 4 factors are in different ways contribute to increase in trend of leptospirosis. And in addition to that, lack of awareness and the inadequate data are contributing to increase the number of cases of leptospirosis. What about when you talk about environmental, the climate change is, is everywhere and leading to increased disasters and extreme weather patterns. And now it's recognized as one of the major contributing factors in increasing leptospirosis as well. The urban epidemics are reported in cities throughout the developing world, mainly contributed by ever-increasing rat population. And world's slum population is estimated to be doubled by 2030, and which these areas provide very conducive environment for the rapid spread of leptospirosis. Then what about reservoir animal? There are nearly 20 different types of mammals that are capable of harboring and excreting leptospira pathogen. Rats considered to be the most effective asymptomatic carrier, and their numbers are ever increasing in both urban and rural settings. Out of the many domestic animals, dogs, cattle, and pigs considered to be the most important. Perhaps in Sri Lanka, stray dogs play a very important role in spreading the disease. The human factors, the host factors. The great majority of infected patients with leptospirosis develop only mild symptoms, and only 10% of patients develop severe cases. This difference in mild cases, now this induced leptospirosis infection induced immune reaction. This immune response determines the severity of illness. So in mild cases, the immune response that develops in these patients is well regulated and is fine-tuned to control the infection quite early. But in severe cases, this immune reaction goes out of control and it becomes overwhelming, and it goes to develop, it's dysregulated and leading to cytokine storm and ultimately immune paralysis and multi-organ failure. It behaves just like sepsis. So this is the deciding factor of determine the severity and the ultimately deaths. What about the pathogen? Old versus new world serotypes are there. And newer techniques in multi-locus sequence genotyping has helped to identify large number of newer serotypes. Now, evidence from various research papers supports the notion that newer serotypes of leptospira may exhibit increased virulence and as compared to old world serotypes. Clinical reports indicate that the infection with newer serotypes often results in more severe symptoms, including renal failure, pulmonary hemorrhage, and myocarditis. So, in Sri Lanka, the question is whether we are moving to a newer serotype because of the ever increasing cases of myocarditis and pulmonary hemorrhage. That's a feature of newer serotypes. Now, the traditional teaching is that milder form of leptospirosis are anicteric, and icterus gives the indication that it is a severe form of leptospirosis. But now that this point is little controversial according to the studies done here. One of the studies done in southern part of the country shows that 94% of our patients had acute kidney injury on admission, and then they developed 40% of patients developed pulmonary hemorrhage, and nearly 1/3 of patients developed myocarditis. More than half, nearly 60% of our patients had hemodynamic instability, which is a very important finding in all these severe cases of leptospirosis, and only half of the patient had hepatic dysfunction. Now, another study done in Galle at Karapitiya, we found that nearly 60% of our patients had evidence of pulmonary involvement. So, the severe leptospirosis patients may or may not be icteric. The clinical features will depend on the organ or organs involved. It may be renal, cardiac, pulmonary, or hepatic. An important fact is that when you compare mortality, leptospirosis, the pulmonary leptospirosis, pulmonary hemorrhage, we call it respiratory leptospirosis, has much higher mortality. It's nearly 70% of mortality as compared to the traditional hepatorenal, that is called Weil's disease, which is nearly 10% as compared to respiratory leptospirosis. Myocarditis is another very dangerous complication which usually coexists with respiratory leptospirosis. So, when this is a very deadly combination, when two coexist, mortality goes very high, further high. The last year, out of the 203 deaths, we managed to properly do an analysis of deaths of 35 cases, and out of this 35 death analysis, we found that 20 were due to pulmonary hemorrhage. So, there is an epidemic of this new version of respiratory leptospirosis spreading across the world. First case described in Nicaragua in 1995. After that, there were several other countries started reporting the same clinical scenario. And 2008, Sri Lanka from Galle reported an autopsy series of 25 cases of pulmonary hemorrhage. And in 2019, we reported from Karapitiya again more than 100 confirmed cases of pulmonary hemorrhage. And last year also, a case series reported from Galle. So, it's a well-established clinical entity in southern part of the country and perhaps spreading across the country now. So, pulmonary hemorrhage could be a manifestation of Weil's disease as a part of multi-organ failure, multi-organ involvement. Then what is this new version we are talking about? This new clinical entity, their presentation is very aggressive, and they present with short acute respiratory distress and massive hemoptysis at times. And sometimes they go into severe multi-organ failure within short period of time. And there is associated ARDS, and this cause of this illness can be called rapid and fulminant cause. An important thing to note that often they don't develop clinical jaundice or significant renal impairment, which differentiate it from Weil's disease. So, the minimal renal involvement and liver involvement and their platelet counts would be near normal, and no significant coagulopathy in these patients. So, When I describe this case, you will understand better. This is a case vignette that is going to showcase what I am trying to describe you. It's a 45-year-old cinnamon worker who presented to Karapeti Hospital with 4 days history of fever and myalgia, and with a positive exposure history for leptospirosis. It's a typical case of typical history of leptospirosis. And on admission, he was hemodynamically compromised and his blood pressure was 80/60 and he was tachypneic. 3 hours later, he started becoming more dyspneic and he became restless. And chest X-ray done on admission was looking quite normal. And 6 hours later, chest X-ray repeated because of the condition deteriorated. You can see the difference and how rapidly it has progressed into a bilateral shadowings and very suggestive of pulmonary hemorrhage. And so this is what is called rapid and fulminant course of this patient's progress. I don't know, our senior physician, Dr. Saraj Gamini is on the chair, and he has been working here in the same place, same hospital for nearly more than 1 decade. But I don't know whether, so you have seen this kind of leptospirosis case during your period, because that indicates that we are seeing this new trend, and this disease form has definitely evolved into a much virulent and much worse form. So what are the clinical features of leptospirosis pulmonary hemorrhage? The earliest feature, if you carefully observe these patients, they become tachypneic. And if you are not going to observe this patient very carefully, you might miss this. And then if you have the facility to, if you do arterial blood gas, it will show arterial hypoxia. These are very early stage changes that usually might miss in inexperienced hand. Later on, they will start dropping saturation, peripheral saturation will be dropped, and they might cough out blood. That takes some time. And later on, you can see the hemoglobin drop due to increased bleeding, internal bleeding, and chest X-ray infiltrates appears much later. So that's why if you wait this patient until they develop hemoptysis and chest, the X-ray findings, so that will be sometimes too late. How are we going to manage these patients? We can describe this initial management of these patients as a bundle of care. Early detection, early recognition is very important. Once you detected a patient with leptospirosis, better to keep an eye on to identify whether this is a severe case of leptospirosis or not. Now, if it is a severe case of leptospirosis, just keep an eye on whether the patient is going to develop respiratory symptom, and cardiovascular monitoring is essential. The fluid resuscitation is very important, not to overload these patients, especially if there is a lung involvement. Antibiotics, IV antibiotics, definitely indicators in severe form of leptospirosis. Iron drops are very indicated because, as I told you before, 60% of our patients presented with hemodynamic instability. They need inotropic support initially. Oxygen therapy is quite essential to save their life, and scaling up oxygen therapy is quite important, and time of intubation will determine the future outcome of these patients. Renal replacement is quite handy and will definitely reduce the mortality, and blood and platelet transfusion may be indicated wherever it is necessary. Then regarding specific management of pulmonary hemorrhage, as pulmonary hemorrhage seems to be an immune-mediated lung injury, immune modulation and immune suppression plays an important role in the management. So we have two options. One is steroids. Using steroids, mainly methylprednisolone. If you use it in quite early stage of pulmonary hemorrhage, that is quite useful, and we have moderate evidence to prove that the benefits effect of steroid use in pulmonary hemorrhage in early stages. Then the plasmapheresis, which is a relatively cheaper and widely available therapeutic procedure in Sri Lanka, and also this procedure has been used in other pulmonary hemorrhagic conditions in the lung, such as Wegener's syndrome. Now, it helps to remove the unwanted or harmful immune products from the plasma. So there are a number of case reports in the literature mentioning that it is the beneficial effects of therapeutic plasma exchange. So in 2017 at Teaching Hospital Karapiti, we started using plasmapheresis as a therapeutic modality in these our patients. And initial 6 cases we treated, we found that it was quite effective, and that encouraged us to use it regularly. Over the next 2 years, from 2017 to 2019, we continued to use this therapeutic procedure, and we compared our results, pre-TP and post-TP results, and published our data in BMC infectious diseases. And this is what we found, and we recruited nearly 80 patients to this study, and out of that 59 patients were treated with plasmapheresis, of whom 42 survived, and we achieved more than 70% of survival rate. Whereas out of the 19 patients who did not have plasmapheresis and who had standard care, only 2 patients survived, and there the mortality rate was more than 80%. Now, mind you, this is not a randomized trial. So this is a case series or observational study, and we tried to do a randomized trial after that, but it was very difficult because randomizing a critically ill patient of this sort to a standard treatment or depriving their opportunity for plasmapheresis would be very difficult among ours in our setting. Because of that, we failed miserably in trial because we didn't have any patients for the control. So this is the evidence we have at the moment, and with this successful finding, actually countrywide, the preferred mode of treatment for pulmonary hemorrhage is plasmapheresis. And what is the future? We need to improve our diagnostics. Otherwise, we'll be guessing from the beginning, and most of the time, this clinical picture can be complicated with other sort of infections as well. And because of that, actually the quality of our research data is also very, very poor because of the lack of proper confirmatory test. The rapid antibody test and a PCR should be made available at least in the tertiary care hospital. And we need to identify the specific sero causing this pulmonary hemorrhage. For that, we need culture isolation and multilocus sequence typing to identify this specific sero at least at the reference level, which is not available in our country at the moment. And already we have made a proposal to WHO to list leptospirosis under neglected disease, and we have already started developing national guidelines, revision of national guidelines, and desperately we need local research to investigate pathophysiology and treatment modalities of leptospirosis, pulmonary hemorrhage. So in summary, leptospirosis is an escalating threat, especially in the tropics. Multi-organ involvement contributes to increasing mortality, and pulmonary hemorrhage mortality is more than 50% and needs special attention to unravel its complex etiology. Steroids and plasmapheresis seems promising in leptospirosis pulmonary hemorrhage, however need more studies to support their use. Leptospirosis causes severe but transient organ failure in healthy people. So most important thing is that these people, once they recover, there is no sequelae, and they recover fully, 100%. It is very rewarding to treat these patients. We need to improve diagnostics, and modern treatments started promptly will improve the outcome. Thank you very much. These are my references. Thank you.
Thank you, Dr. Uluwatke. We'll discuss this during the discussion time, right? Next, the last speaker in this symposium is Dr. Erand Narangoda, who will talk to us on Mpox, something new to most of us, what you should know. Now, Dr. Narangoda is a consultant physician at the National Hospital of Infectious Diseases, Colombo. He got his MBBS in 1999 and MD in 2007, and he's a fellow at the American College of Physicians. Dr. Narangoda, please.
Thank you very much, sir, for the introduction. Good afternoon to you all. First of all, let me thank the presidents and the councils of SLMA and GMA for inviting me to do this presentation on Mpox. Mpox has been in the limelight over the past few years due to a global outbreak outside of its endemic African territory, and there has been a spread of a new variant this year in Europe and certain other countries, including our neighboring countries like India and Pakistan. So we have to be on the alert to identify these patients early to prevent any spread in our country. So during the next 15 to 20 minutes, I'll be briefing you on the virology, mode of transmission of this infectious disease, and more about the clinical features and differential diagnosis, and briefly about the management as well. Mpox, which was known as monkeypox earlier, is caused by the virus monkeypox, which belongs to the genus orthopox virus in Poxviridae family. The other well-known viruses in this genus is smallpox, cowpox, and vaccinia virus. Smallpox was eradicated from the world in late 1970s, and we see sporadic cases of human cowpox cases on and off. So Mpox virus is a double-stranded DNA virus which has the shape of a brick, as you can see in this picture. It can exist in two distinct forms in the host. The extracellular enveloped virus, which is the immature form, which gets into the target cells of the host to become intracellular mature virus. And there are distinct genetic subvariants. We call them as clades. Clade 1 and clade 2 have been identified so far. Clade 1 is endemic in the Central African region, like Democratic Republic of Congo, and clade 2 is seen in Western African countries like Nigeria. Clade 2b was responsible for a global outbreak in May 2022, which went on till the late 2023, and there has been sporadic cases of clade 2, and clade 1 is the newer variant or the subvariant, which is spreading in the Europe, and this made WHO to declare Mpox as a public health emergency of international concern last August. So this Mpox disease, it's a viral zoonotic disease that spreads from animals to humans. The exact animal reservoir is not very clear, though we call this monkeypox. So humans can get this disease from rodents and also non-human primates like monkeys due to scratches and bites of these animals, and also handling the infected meat and eating raw meat can also transmit the virus to humans. Then after that, human-to-human transmission can occur in households as well as in institutions. through close contact with an infected individual, including the direct contact with the skin lesions and the respiratory droplets. And this contact has to be a prolonged close contact. So we see human-to-human transmission mainly in intimate sexual contacts like heterosexual and homosexual contacts. And also droplet transmission is also possible, again with close proximity. Airborne transmission of droplets has not been reported. Then another important mode of transmission of mpox is through fomites, that is contaminated materials such as bedding, clothes and other linens, and also the objects which has come into contact with the infected individuals. Especially linen, these skin lesions, the remnants of the skin lesions and exudates can remain in these clothes and can be a mode of transmission, especially if you shake them or if you dry dust them, there can be some amount of airborne transmission as well through the fomites. The virus gets into our body through the mouth, nose, pharynx and the damaged skin and replicates at the site of the inoculation, and then it spreads to local lymph nodes, causing a lymphadenopathy and also some prodromal symptoms. Subsequently, they get into the other lymphoid organs such as tonsils, spleen and liver, replicate again in these organs, causing a second wave of viremia. And they can get into distant organs like kidneys, brain and lungs to cause various complications. When you look at the clinical features, these patients can be asymptomatic as well as symptomatic like any other viral infection. We don't know exactly the percentage of asymptomatic individuals because we don't test the asymptomatic ones, but they are thought to be contagious. Then the clinical phase the clinical features has two phases, the prodromal stage and the eruptive stage. The incubation period is 3 to 21 days. And during the prodromal phase, you get a fever which can be low grade or high grade with associated constitutional symptoms like headache, myalgia, body aches, and so on. And also, lymphadenopathy is seen during this prodromal stage. After 2-3 days, the skin lesions appear, which evolves in stages as shown in these pictures. Initially, you get macules, which becomes papules after 1 or 2 days, and these papules are deep-seated, thick-walled papules, which do not break easily, and after another 2-3 days, they become vesicles, like in chickenpox. Again, these vesicles are also thick-walled and not easily breakable. After another 1 or 2 days, the vesicles becomes pustules. These pustules are not true pustules containing pus. They contain cell debris, which are sterile. And some of these pustules undergo central umbilication, as you can see here, which gives the appearance of the skin rash of molluscum contagiosum. Then these pustules remain about a week, which becomes crusted later on, causing scabs. So at the recovery phase, you get these scabs which fall off, leaving depigmented, depressed skin areas as you can see in this picture. Once all the scabs have fallen off, they are no more contagious, and that takes 2 to 3 weeks. So the inoculation of the lesion is considered at the site of the inoculation. Can involve skin as well as mucous membranes like the oral cavity, conjunctiva, and also the anogenital mucosa. And the size of these lesions vary from 0.5 to 1 centimeters. The distribution of the rash is quite different from the chickenpox, which is the closest mimic of this skin rash. It has a centrifugal distribution, which means it starts from the face and then extend to the arms and face, the extremities, also to the palms and soles. Trunk involvement is not very prominent. And these lesions, especially the vesicles and pustules, can be very painful. Later on at the scab formation stage, they become itchy. So once a person develops these prodromal symptoms, if they do not develop the skin rash within the next 5 days, you can confidently exclude monkeypox, because this rash is almost always seen in these patients. This is an example of the papules of monkeypox. You can appreciate here that they are discrete lesions with thick walls, shiny thick walls, and you can see all the lesions here are papules. These are the vesicles with the pustules with central umbilication in the genital region and also the oral cavity. These lesions might look like herpes simplex lesions, because both are quite painful. Again, some slides of different stages. The first one there is the umbilicated pustules, and then blisters and the papules. So how do you suspect these patients and investigate further? If somebody has all these clinical features of prodromal symptoms followed by the typical skin lesions, and if there's you have to consider epidemiological data as well. There should be a history of close contact with a suspected or confirmed case of mpox within the last 21 days. So such patients, you have to isolate them and investigate further. The differential diagnosis is the most difficult thing to differentiate this from the other skin rashes is varicella infection, chickenpox, or even herpes zoster, because both these rashes evolve in stages. Then measles also you have to suspect in a patient with fever and a rash, especially though we have eradicated measles, we still see few cases, and in measles the rash is just macular papilla and they don't evolve into blisters or pustules. Then you have to suspect other sexually transmitted diseases like herpes simplex, gonococcal infection, then lymphogranuloma venereum, which are all STDs. If mpox patients have only anogenital lesions due to the sexual contacts, they can mimic all these sexually transmitted diseases. And also primary and secondary syphilis. Primary syphilis is, as you all know, it's where you get a chancre, just a solitary lesion. Sometimes mpox also you can get only 1 or 2 lesions, which might make it difficult for you to differentiate this from primary syphilis. And the secondary syphilis rash also sometimes resembles the monkeypox rash because it involves palms and soles. Then molluscum contagiosum is the other differential diagnosis if the patient presents at the stage of these pustules. So this is a patient who presented to us some time ago with fever and a rash. He was from a European country. So I have zoomed the picture so that you can appreciate some of the classical features of this skin rash. You can see here there are lesions at different stages. Some are macules, some are blisters, and some papules, and they are of different sizes. And when you look at the wall, they are not thick-walled vesicles. You see a shrunken appearance. So how do you differentiate the two, chickenpox and monkeypox? These are the important features which would help us to differentiate the two. In chickenpox, you don't get lymphadenopathy unless it's infected, secondarily infected, which is not quite common. Whereas in monkeypox, you almost always get lymphadenopathy during the prodromal stage. Then the distribution is different. This centripetal distribution you see in chickenpox patients, where it starts from the face and then involves mainly the trunk, whereas in monkeypox, it starts from the face and then spread to the extremities, limbs, palms and soles. Then another important thing is palm and sole involvement. Soles involvement you don't see much in chickenpox. And mpox lesions are painful, whereas chickenpox lesions are usually not painful. They can give rise to some irritation, but not much of pain. Then the papules of chickenpox are classically superficial and fragile, as you saw in the earlier picture, whereas monkeypox papules are thick-walled and they have a shiny appearance. Then the progression of the lesions is faster in chickenpox, which evolves into crusting stage within 7-10 days in chickenpox, whereas monkeypox takes 2 to 3 weeks for crusting to happen. And the other important thing is these skin lesions, at the same site, you get the same lesions. That means in chickenpox, you get different lesions at the same site, at the same anatomical site, whereas in monkeypox, they evolve together at the same anatomical region. So now you can differentiate the two. This is varicella zoster or chickenpox, where you get lesions at different stages, and also their walls have the shrunken appearance, whereas the monkeypox papules are quite discrete, bigger than the chickenpox papules, and also they have thick walls and they are not easily breakable like chickenpox. This is another example of chickenpox and monkeypox. The same characteristics you can appreciate here as well. These are blisters, the vesicles. You can see in the first picture the coalesced vesicles of chickenpox, and in monkeypox you get discrete lesions. In Sri Lanka, we had 4 cases of mpox in this 2022-23 global outbreak. All of these 4 patients were treated at our institute IDH. 2 of them were adults and 2 children, including 1 neonate, and 2 of them were diagnosed in November 2022 and the other 2 in June 2023. These are the pictures from our patients. We suspected Mpox in these patients because of the epidemiological connections, because some of them were foreigners and some had foreign visits to countries where there was Mpox. And the lesions, you can see they are bigger than the chickenpox lesions and more discrete and stable papules. So Mpox and herpes simplex also you have to differentiate because both are painful lesions. In herpes simplex, you don't get papules or pustules. They start with vesicles and erodes to cause ulcers. And in herpes simplex, you get a previous history of painful skin lesions because they remain dormant and give rise to acute episodes later on. So co-infections of monkeypox with sexually transmitted diseases has been reported during the 2022 outbreak as well as during this 2024, this year's outbreak as well. Most of the patients that have got the disease this year are males and they have sexual contact history. So it's very important to investigate or test for other sexually transmitted diseases in these patients. Then the complications are, you can get proctitis, urethritis if there are anogenital lesions. The involvement of the eyes can cause catastrophic effects like scarring and ulceration, which can lead to permanent blindness. Then pneumonia, encephalitis, those conditions can happen. GBS, that is Guillain-Barré syndrome, and transverse myelitis is seen during the recovery phase. And preterm delivery, stillbirth, and neonatal Mpox are seen as a complication of pregnancy. So how do you diagnose monkeypox? The diagnostic test available in our country and in most other countries is RT-PCR. Like COVID, we have to take samples from the skin lesions. You can take samples or swabs from the papules and pustules, or else you can send the crusts in different bottles, and you have to take multiple samples to improve the yield. And also, if the patient does not have much of skin lesions, you can send a nasopharyngeal sample as well if they have respiratory symptoms. And the other blood investigations like full blood count, AST/ALT, liver transaminases, and CRP, these investigations are also important. Most of these patients show thrombocytopenia and leukocytosis in their full blood count, and AST/ALT can be slightly high, and also CRP is high only if there's a secondary bacterial infection. Then briefly on the management, main treatment is the supportive care, because most of these patients have mild to moderate disease, hydration, antipyretics, and analgesics. And also if they have severe disease or if they have involvement of anatomical areas which can give rise to serious consequences like corneal scarring, you can use antivirals. Antiviral which is available to us is this tecovirimat, which is, I think it's still not registered here, but it was available to us during the last few years through the WHO for the patients who are having severe disease. Then the other most important thing is isolation of these patients and contact tracing to prevent the spread of the disease. A little bit about the skin care. You can ask the patient to wash with soap and water and then keep those lesions covered because by covering the lesions you can reduce the spread of the virus. And also you should ask them to avoid scratching or de-roofing the lesions because that can give rise to secondary bacterial infections and also it gives rise to higher chances of spread. And for anogenital lesions you can recommend sitz baths and other hot and cold compressions to ease the pain. Then antiseptics you can use if there's secondary bacterial infection. If you are suspecting, then to prevent scarring you can use silicone based gels. And also it's important to advise them to avoid sunlight after recovery to avoid hyper or hypopigmentation of these scars. So that's about it. So the take home message that I want to convey is that as there's a global outbreak and we have a lot of tourists these days, so if you are suspecting chicken pox, think about mpox as well in a person who has a travel history or who is a foreigner, and see whether it's mpox or chicken pox. Thank you.
Thank you, Dr. Narangoda. I wonder whether we have time for any questions. If there are any burning questions, please, because we have run over time now. Dr. Piesari, Dr. Uluwatage, can we have one come? Bhagya. Without wasting time, if I can ask questions before they come, about melioidosis, Dr. Piesari. Now, we have the habit of giving meropenem, at least in Colombo. I know what's happening in Gaul. Any patient with high white cell count, fever, ill, we start giving meropenem before maybe we take a blood culture. Will that obviously prevent the diagnosis of melioidosis?
Not necessarily, sir. Sorry. You should carefully assess the indication actually. Now, when a patient comes with fever and suggestive features, you need to you need to assess the condition, the severity, the presentation and the comorbidities, everything. I mean, just because the patient comes with fever, you don't have to start on meropenem always because it could be anything. So, likewise, I said that if it is a deep-seated abscess, severe pneumonia, with severe comorbidities, patient is septic shock, then you may go for meropenem as per the recommendations, but after the blood culture. But not always.
Yeah, but then you have to accept the reality. I know, that's why I said, in Colombo, the tendency to give meropenem, whenever a patient comes with these very ill patients, high white cell count, taking a blood culture and start on meropenem. Sorry to say, but that could be the reality. So what I am trying to say is, maybe we are missing a lot of patients of melioidosis because of that. Could it be?
But if the blood culture was taken before the...
Is it the same culture medium? That
yes, sir. Routine culture medium. It goes very well on the routine culture medium.
Jennifer Perra, what have you got to say? Okay, thank you. Yeah, we are running out of time, I'm sorry. Yeah, only 15 hours. So thank you very much. Can we have the certificates of appreciation?
Thank you, our esteemed chairpersons and speakers, for that excellent and informative session. I'd like to invite the chairpersons to present the certificate of appreciation to the speakers. Move on to our final item on today's agenda. The guest lecture titled Beyond the Mirror, Systemic Drugs and Oral Supplements in Anti-Aging Dermatology. This will be delivered by Dr. Achara Liyanage, Senior Lecturer and Specialist Dermatologist at the Faculty of Medicine, University of Ruhuna.
Good afternoon, ladies and gentlemen. First, let me thank the organizing committee of the foundation sessions of Sri Lanka Medical Association in collaboration with Galle Medical Association for inviting me to do a guest lecture. The topic that I have selected for today is Beyond the Mirror, Systemic Drugs and Oral Supplements in Anti-Aging Dermatology. I hope you have watched the Disney movie Tangled. Each and every one of us are eagerly waiting to have something magical similar to what Mother Gothel got from Rapunzel. However, in my talk today, I will discuss the reality, but not the magic. With that in my mind, moving to the lineup of my talk, first, I will introduce anti-aging dermatology, then place for oral supplementation and their concerns. Next, evidence on oral supplements and systemic drugs in skin aging. And finally, limitations and considerations. As the global population ages, including here in Sri Lanka, maintaining a youthful appearance has become an important aspect of healthy aging concept. This growing interest has driven high demand for anti-aging treatment. Anti-aging focuses on preventing, slowing, or reversing the visible signs of skin aging through various interventions. In this lecture, I'll be focusing specifically on the evidence base for systemic supplements and medications for anti-aging. So there are two types of factors involved in aging process: intrinsic or chronological aging, which include genomic instability, cellular senescence, and shortening of telomeres. And in extrinsic aging, the external elements, example, chronic light exposure, radiation, pollution, chemical toxins, expedite the aging process. Both extrinsic and intrinsic factors induce reactive oxidative stress, which activates all sorts of signaling pathways, leading to upregulation of matrix metalloproteinases. And these reactive oxygen species also results in oxidation of lipids, leading to DNA damage, which causes cellular dysfunction. Therefore, aging is essentially a complex process with many other molecule signaling pathways. not only in the matrix metalloproteinase activities, there are so many biochemical pathways get altered with aging as listed here. And these biochemical changes are reflected clinically as compromised skin aging, increase in fine wrinkles, reducing skin elasticity, and aberrant pigmentation. Other than the chronological aging, photoaging has different set of clinical manifestations, which are more prominent and often quite distressing. In this picture of a lorry driver having marked photoaging on his left side compared to the right side having the intrinsic aging alone. Therefore, it is important to treat and enhance the skin health and aesthetics specifically to address the psychological and social impacts of skin aging. A wide range of treatment options are available, from natural remedies and lifestyle modifications to topical products, procedural interventions, and systemic approach with oral supplementation and oral drugs. In the systemic approach, both oral supplements and oral drugs are being used in the treatment of anti-aging. The oral supplements can be broadly categorized into vitamins, antioxidants, plant extracts, and collagen. The systemic drugs that are implicated in the treatment of anti-aging include isotretinoin, tranexamic acid, glutathione, and hormone replacement therapy. Now, all these agents work through biochemical pathways associated with aging, namely as antioxidants, pigment regulators, molecules that are targeting epidermal renewal, and extracellular matrix regeneration. Among these systemic treatment, oral supplements have become significant component in anti-aging dermatology due to their potential to support the skin health from within, unlike topical treatment which target the outer layers of the skin. They work by delivering the key nutrients, antioxidants, and structural compounds that support the integrity, resilience, and the appearance of the skin at a cellular level. So in my next few slides, I will briefly elaborate these oral supplements with regard to their mechanism of action and the evidence with efficacy and recommendation for skin anti-aging. Vitamin A as an oral supplement for skin aging is involved in many biochemical processes such as inflammation, proliferation, cellular differentiation, and turnover. It is also be able to stimulate the collagen deposition by reducing the matrix metalloproteinase expression and thereby reducing the signs of skin aging. Now, according to the 3 clinical trials in which vitamin A was used, had shown some improvement in skin aging scores. However, no consensus for its use in skin aging or photoaging. Niacinamide, also known as nicotinamide or vitamin B3, is the next vitamin which was assessed for anti-aging. It has antioxidant properties and is able to repair DNA. It is a component of nicotinamide adenyl diphosphate, which is known to decrease with aging. Therefore, it is assumed that supplementation of niacinamide would provide anti-aging benefits. Sorry. Looking at the evidence, recommendations are drawn for chemoprevention of skin cancers, but insufficient evidence to support its use in the treatment of skin aging. Vitamin C provides protection from UV-induced photodamage mediated through the reactive oxygen species and also helps in collagen synthesis, improving skin integrity, thereby diminishes the signs of aging. A single clinical trial had used vitamin C and had shown some improvement in skin anti-aging parameters. However, insufficient data for the use of it as anti-aging purposes. Vitamin E involved in many aspects of skin health, which much effect on the inflammatory skin diseases. Only 2 clinical trials had used vitamin E matched with calorie match control, with some improvement in the reduction of skin wrinkle severity, but there is again insufficient data for its recommendation. Vitamin D demonstrates anti-inflammatory properties and is also shown protection against UV-induced mutagenic changes in the formation of skin cancers. And oral supplementation of oral vitamin D is recommended in the treatment of eczemas and psoriasis, and also those who are at risk of developing melanomas. And this anti-aging effect of vitamin D is proposed due to its ability of neutralizing reactive oxygen species. However, again, there is no clinical trial which had used vitamin D for anti-aging purposes. So in summary, regarding the vitamin supplements, although they are very popular, perceived as natural and safe among the general population, and the demand for them is on the rise, the evidence supporting their effectiveness is weak. The next category is polyphenols, which are plant derivatives produced as protection against stresses. They have antioxidant and anti-inflammatory properties. The commonly used polyphenols include pomegranate extract, curcumin derived from turmeric, green tea extract, grapeseed extract, and fern extract. Among the polyphenol derivatives, clinical trials had used turmeric, fern extract, and pomegranate peel extract, all of which had shown some benefit in skin aging parameters, also known to cause harmful effects like hepatotoxicity and interactions with drugs such as warfarin with higher doses. So there is insufficient data for specific dosing of these polyphenol derivatives for skin aging purposes. Another concern regarding these high concentrations of polyphenol derivatives is that it is potential to protect cancerous cells in addition to the healthy ones, leading to unintended effects. Astaxanthin, a naturally occurring carotenoid nutrient on living organism, has strong antioxidant properties, and also it suppresses the inflammation and DNA damage. There are about 8 clinical trials which had evaluated astaxanthin for skin aging, and based on the pooled results of a recent meta-analysis, as shown in this forest chart, astaxanthin favors the increase in skin moisture, improves in skin elasticity, although there is much heterogeneity of the studies is noted here. Thank you. And regarding the wrinkle depth, the standard mean difference was not significant compared to the placebo. So promising results have been observed with extracts from plants, but clinical evidence is lacking. Oral hyaluronic acid supplements is another novel treatment that could help to mitigate the effects of skin aging. It is a mucopolysaccharide widely distributed in the connective tissue, and the skin contains about 50% of the all hyaluronic acid in the body. It is also important in regulating the water balance and maintaining the structure of the skin. Number of clinical trials conducted on hyaluronic acid supplements with different dosages have shown to increase skin hydration, improvement of skin wrinkle volume, as well as the depth. So based on these clinical trials conducted, it could be concluded that it is well tolerated. However, the optimal doses, molecular weights, and the duration of treatment yet to be determined for hyaluronic acid supplements. Oral collagen supplements. The collagen is the main structural protein in the skin. which accounts for about 75% of total weight of the extracellular matrix. And the hydrolyzed collagen supplements are obtained from the enzymatic hydrolysis of the natural collagen derived from fish or marine collagen, pork porcine collagen, or collagen from chicken. And this is the process of obtaining hydrolyzed collagen used in the oral supplement, and amongst them, marine collagen and its peptides have higher bioavailability, potency, and favorable safety profiles. In recent meta-analysis of 24 clinical trials, use marine collagen on skin anti-aging have shown its efficacy in skin hydration and effectiveness in the improvement of skin elasticity and also improving the wrinkle depths. Therefore, oral collagen supplements has the strongest supporting evidence in skin anti-aging. However, optimal doses and duration of treatment remains to be determined. Talking about the concerns of these oral supplement use is that there are many available products which are often unregulated, and the supplement claims can be easily misleading. And the promising benefits that they claim may lack the real efficacy or safety validation, particularly in the presence of so much comorbidities and also interactions with the prescription medications, and whether it is safer to be used if it is in excess. So lack of third-party laboratory testing is also concerning with regard to the quality, purity, and safety of these products. So it is quite alarming to see the supplements that are available in the local market over the counter or as online purchasing. So therefore, clinicians should be aware about their efficacy, interactions with the usual drugs, and safety. Moving to the systemic drugs, isotretinoin is a retinoid widely used in the treatment of acne and many other skin conditions. It has anti-inflammatory properties and also appears to be capable of inhibiting extracellular matrix metalloproteinases and increasing collagen production. There are numerous studies conducted using isotretinoin in skin aging using low doses of isotretinoin. However, very limited evidence regarding the improvement on skin aging. So regarding isotretinoin, it could be concluded that it might be useful in the treatment of skin aging, but insufficient evidence to recommend oral isotretinoin over topical retinoid treatment due to the potential adverse effects, namely mucocutaneous dryness, lipid and liver changes, and teratogenicity. Oral tranexamic acid is a plasmin inhibitor and is known to have a potent anti-inflammatory and depigmenting properties. There are numerous clinical trials have demonstrated their efficacy in the treatment of melasma, which is a photoaging disorder, but no prospective clinical studies evaluating its effect on skin aging. Hormone replacement therapy, as women can lose up to 30% of skin collagen in the first 5 years of menopause and experience 0.5% loss of skin elasticity each year, it is assumed that HRT has a place in skin aging. A recent meta-analysis had shown HRT favors increased skin collagen content, but again there is so much heterogeneity in the studies assessed. Further, there is also a reduction in facial wrinkles, but not so with the improvement in skin dryness. Oral glutathione, which has multiple roles in skin health, as antioxidative, anti-tumor, antiviral, anti-melanogenic. Since decreased glutathione levels are associated with the common features of aging, it could be assumed that supplementation of glutathione is beneficial. Going through the evidence of recent 3 clinical trials, it has only shown some effect on pigmentation. You can notice that it is very short duration studies, but no evidence to recommend for skin anti-aging. I want to highlight some points regarding limitations and considerations in this area of research. One is that these data are mostly from small and predominantly female samples. And also, these studies tend to have very short durations. And in addition, there is considerable methodological heterogeneity of these studies. And lastly, there is lack of consensus on which outcome measure is clinically relevant. So, ladies and gentlemen, I have reached the end of my talk. To summarize, there is no strong clinical evidence supporting the use of vitamin A, C, D, E, niacinamide, glutathione, or tranexamic acid. Among the polyphenols, astaxanthin may be beneficial for reducing skin aging, enhancing skin moisture and elasticity. Evidence for isotretinoin remains insufficient, and safety concerns necessitate caution before its use. Further evidence on HRTs or hormone replacement therapy effects on skin aging is needed with careful consideration of cardiovascular and breast cancer risks. Oral hyaluronic acid may help to reduce the skin signs of skin aging, while oral hydrolyzed collagen has the strongest supportive evidence to date. Thank you for your attention.
Thank you, Dr. Liyanage, for that informative and interesting talk. I'd like to invite Dr. Surantha Pereira, President-elect of the Sri Lanka Medical Association, to present the Certificate of Appreciation to Dr. Liyanage. As we draw to the close of today's sessions, this invitation goes to Dr. Udari Egudage, Joint Secretary of the Gaul Medical Association, to deliver the vote of thanks.
Good afternoon, ladies and gentlemen. The Sri Lanka Medical Association, being the oldest professional medical association in Asia, holds a rich tradition of academic excellence. Their foundation sessions are a highlight of their calendar and has been a true honor for the Gaul Medical Association to collaborate with them for this event. First and foremost, I wish to express my gratitude to the President of the Sri Lanka Medical Association 2024, Dr. Ananda Wijevikrama, and the SLMA Council for entrusting us with this incredible opportunity. Beginning with the inauguration yesterday, followed by the keynote speech, oration, impactful symposiums, and guest lectures, this morning, this event has truly been a resounding success. I would first like to congratulate our orator who delivered Sir Marcus Fernando oration, Dr. Nilanka Vikramasinghe, lecturer in physiology, Faculty of Medicine, University of Colombo, for delivering an exceptional oration And thank you for entrusting this forum to share your scientific work. I should thank the keynote speaker of SLMA Foundation Sessions, Emeritus Professor W. Indradal de Silva, for accepting the invitation and being a key resource person in this event. A heartfelt thank you goes to all our distinguished symposium speakers and guest speakers for the wealth of knowledge imparted through your insightful presentations. Your contributions have significantly enriched this event. We are deeply grateful for the invaluable support from the Faculty of Medicine, University of Ruhuna. I must thank Senior Professor Tilak Veeraratne, Dean, Faculty of Medicine, University of Ruhuna, for his encouragement and continuous support for academic activities, and also for permitting us to use the faculty auditorium and its facilities. I would like to specially acknowledge Dr. Lahiru Kadituaku, the SLMA Secretary, for his tremendous support and commitment. I should mention that much of the groundwork was carried out by the dedicated SLMA team. Therefore, I should thank the SLMA council members and office staff for their hard work and dedication. Further, I should thank all the SLMA members who are here today for gracing this event with your presence. From the GMA end, I extend my gratitude to our President, Dr. Vimala Suluwathage, my Co-Secretary, Dr. Larindra De Silva, and the council members for their unwavering support. Additionally, I must thank our office staff, Mrs. Sureka and Mrs. Savitri, as well as Mr. Kumara and Mr. Vasanta for their invaluable contribution to the event's success. I would also like to thank our sessions compeer, Ms. Samudirohana, for her excellent comparing, and our third year medical students for their assistance with ushering. A special note of appreciation goes to all our service providers for their exceptional work. Mr. Sujiva and Tamarind Company for event coordination, Wilson Flora for flower arrangements, Blue Fox Restaurant and Hikkadua for arranging food, and Nila Studio for photography. Thank you all. I thank Dr. Kalna Vidana Patrana for coordinating the entertainment interlude, and I wish to thank the group of doctors, medical students who performed at the inauguration amidst a very busy academic life. Finally, a big thank you to our sponsors, coordinated by both SLMA and GMA teams, and to everyone here, doctors from different parts of the country, faculty staff, nurses, and medical students, for your participation and support. Thank you all once again, and I look forward to future collaboration and continued success together. Have a nice day.
Thank you, Dr. Godage. Ladies and gentlemen, with this we conclude the foundation sessions of Sri Lanka Medical Association held in collaboration with the Gaul Medical Association. Thank you for your active participation and engagement. Please join us for lunch before you leave and have a pleasant day ahead. Thank you.